and I'll be co-chairing this event with Pam Core, who's the Head of Financial Development at University Hospitals of Coventry and Warwickshire. So just a bit of background, just to start the session off. So this is a Demystifying NHS Finance Day. It's a national study day as part of the One NHS Finance programme, which is the NHS England sponsored programme, hence it's free. And the idea of today is to cover the basics of NHS finance. We're not trying to get you to be accountants. We're not trying to get you into a lot of detail. This is very much the basic building blocks on which you then can build on if you so wish. And we'll give you some links to some resources that and further courses that may be useful to you if you want to learn more. Pam, do you want to just say hello and introduce yourself? And
of course. Hello, everyone. I'm Pam Core. I work at University Hospitals, Coventry and Warwickshire. Been there for 10 years and also been an ambassador for finance and clinical education and the One NHS Finance network for over 10 years now. And I'm looking forward to speaking to you all today and help co-chair the session. Thank you.
Thanks, Pam. So what we're going to try and do is we're going to start quite broad. We'll start at the national level, give you some example, talk about the NHS structure and a bit about how the finances work nationally. And then as the day goes on, we'll try and make it a bit more relevant to people within organisations. And the idea is we try and piece it together, and then we finish it off with kind of business cases and something a bit more specialist. So dip in and out as you wish, that's fine. There'll be some sessions that'll be more relevant to you, some that'll be less relevant to you. The idea is that we are quite broad. There are nuances. We're not trying to go into the nitty-gritty, into too much detail. Every area will have slight differences. Every area, different types of organisations, acute, community, mental health, will have slightly different subtleties in how they operate. So again, we're going to keep this broad, but if you want to ask questions, feel free. We're going to try and make it as interactive as we can. We're going to try and use the chat as much as possible. So I'm kicking off with the kind of broader picture. So as I said earlier, the idea is to try and help you navigate the health system. The idea is that you can use this information to develop your services, to do service improvement, quality improvement, and try and navigate some of the kind of challenges that we're facing at the moment. As I said, we're not trying to make you clinicians. We're not trying to make you accountants. We are focused on the clinical side of things. Patients will always come first, but we do want you to be clinically driven. So your main focus is the clinical side of things and the patients, but just aware of the financial implications of what we're doing. So we work in a finite healthcare system. If we save money in one area and improve our pathways, we can use that money in other parts of the system. So when we talk about finite healthcare systems and trying to make the best use of that money, we use the word value a lot, but we don't always fully understand or appreciate what that actually means. So value in healthcare there's three different types of value. There's something called allocative value, and that's how the resources are divided up. So how you split up the resources that you have. That can be at national level, it can be at a kind of a regional level, an ICB level, or it can be at organisational level. We're not going to focus on that particular aspect too much today. It's also called economic value. What we are going to focus on today is technical value, and that's how you make best the resources that you are given. and that's much more in the remit of most people, and that's called efficient value. And the final one is something just to be aware of, is that it's something called personalized value, and that's just understanding that different people, you, me, patients, may have different values. We see that often in the clinical world, where different people choose different pathways depending on what they value. A kind of academic version of it. So the Virginia Mason Institute, which is an American healthcare system, which is big on value-based healthcare, they've worked with some Welsh health boards, and they did an experiment study looking at personalized, what people want out of their clinical appointments. And so they asked the clinicians in the clinic what they wanted out of what the focus was, or what they wanted out of consultation. They asked the same thing of the patients, and the clinicians wanted to diagnose the problem, they wanted to stop disease progression, they wanted to treat the disease. The patients wanted better sleep, they wanted to feel less tired, they wanted to go to work, they wanted to be able to go for walks, whatever it was. And the reason why we talk about this is that 9 times out of 10, hopefully, most of these values overlap. So the clinicians kind of what they want, and the patients what they want do overlap. But there are occasions where they differ, and it's just an appreciation of that. So it's called effective value. So if we focus down on value, technical value, and we make it into an equation, again, trying to make this a little bit interactive. In the chat, what do you think, one word that goes on the top line, and then one word that goes on the bottom line? What do people think?
I was going to say resource.
Okay, resource.
Time would be one, maybe.
Time, okay.
Number. Volume.
Yeah, I've got a few of the couple of right answers. Well, some of the words. Oh, a couple of exact words. So the top line is quality. The bottom line is cost. So you want to get quality over cost. Okay. Now there are 3 domains. There are 3 components to quality. So what do you think they might be? So if you look at the NHS Constitution, if you look at your organisation's quality commitments, there are 3 domains to quality.
Patient outcome.
Yeah, outcomes. Okay. So outcomes, and it's important to note there's no specific outcome that you're looking at when we're talking about value. It can be anything from length of stay, mortality, complication rate. You've got to choose the right outcome for whatever you're looking at. And an example of that, and again, I apologise, as an anaesthetist, most of my examples are either surgical or theatre based. But one of my colleagues, some of my surgical colleagues, use a different way of closing the abdomen. It adds about half an hour onto the operations when they're closing up the big cuts, laparotomy cuts in the middle of the abdomen. It doesn't affect pain, post-op pain, doesn't affect length of stay, doesn't affect complication rates in 30 days or readmission rates. It doesn't actually do anything for the first year. And so if you used any of our standard outcome metrics, you probably wouldn't find any benefit to it. But over 5-10 years, you notice there's a significant reduction in that wound breaking down, so incisional hernias, so hernias through that cut in the abdomen. and which can be quite painful and cause significant problems. So when you're looking at outcomes, you've got to pick the right one over the right period of time that suits whatever you're measuring. And the other two are patient experience and patient safety. Okay, as has been said in the chat. And then cost. Cost is divided into two generally. You have revenue costs, which are your day-to-day costs. They recur every year, and so they're ongoing costs. And then your capital costs, which are one-off, generally big pay, one-off costs, big purchases, normally building something, buying something with a one-off payment. So that's how you define value. Now, there are kind of two sides to this. And there's one side where when you're trying to put a bit of a business case in, or any kind of service improvement or asking for money, you've got to show that the increase in quality is worth the amount of money you're spending on it. I mean, we could knock down every hospital in England and rebuild it. And in some places, it would be worth it. The increasing quality would be worth the cost, but on others, it would make a difference. Or it would always improve the quality a little bit, but probably wouldn't be worth the cost. So that's one side of things. You've got to show that benefit. You've got to show, ideally, multiple domains, how your quality can improve for your service improvement project. But Michael Porter also said that if you improve quality, you will reduce costs. Okay. The problem is the costs that you reduce might not be to your department, might not be to your organization, might not even be to the health system. It might be environmental benefits. It might be societal benefits, more people in work and all that kind of stuff. And that's not really factored in. It's factored in a little bit more now, but it's not really factored in when we're doing our service improvement and quality improvement projects historically. But generally, improving quality will reduce costs. So if we go into a little bit more about the NHS structure, a little bit about how money flows through the system, and I'm going to touch on payment systems. So the NHS has been involved since 1948. When it was set up, it wasn't really kind of planned. It was a nationalisation of whatever was there originally. And so you had lots of big centres, or in urban areas you had, in the cities you had hospitals, but not much else around the place. And they ran out of money in the first year. So finances for the NHS has been an ongoing problem. In 1962, they came up with this idea of the hospital plan, where they would try and build, they were trying to be a bit more coordinated. They wanted to build a DGA, District General Hospital, for every 125,000 of the population. They started, but they ran out of money. It's an ongoing trend here. Until the 70s, hospitals were very independent. There was no coordination between primary care and hospitals until in 74 they developed the health authorities. In 1990, you had the idea that organisations should compete for work, and the idea was that if you get organisations to compete, you would improve quality and lower costs, and that worked to a degree when there was in the boom periods, when there was lots of money around. It seemed to work, but it didn't. It stopped working quite quickly as soon as money was scarce. So in 2000, you had the NHS plan, you had the Health and Care Act in 2012, which is the last probably significant major reforms to the NHS, and they continued that idea of competition. In fact, they kind of made it a statutory requirement, so made it by law. All commissioners had to put out to tender any service they wanted to commission. And again, the problem was that from its conception to implementation, the world changed. So it's conceived probably in the early in the mid 2000s, and then by the time it was actually implemented, you'd had the financial crisis, and so we went from a time of relative boom to the financial crisis and potential recession. So it didn't seem to work very well. And then for the following 10 years, the NHS has tried to manoeuvre itself within the legal framework that the kind of 2012 reform had. And the most recent reforms are not really that significant in that they did a few big things, but a lot of what they did was tidy up the legislation to allow the NHS to continue working. And most of it was based on what the NHS wanted, NHS England wanted. And they put forward some requests in 2019. And I'll go through that in a bit more detail in a bit. So the money, the amount of money the NHS gets is determined by Parliament, and more specifically the Treasurer, and the Treasury, and the Chancellor does that every 3 years in the spending review. So you get some idea of the budgets, and then it gets adjusted annually by the budget report. Now, the numbers we're going to talk about now might change, as it's likely to be, well, there will be probably a spending review of some sort in November or after the general election. So this is the current forecasted budget. So one thing I always like to get people to do is just compare the budgets of health, education and defence. So either rank them in order or put some numbers as to what you think the budgets might be for health, education and defence. Quite a variety of options. There's a few people who've got the correct answer. So the amount of money spent on healthcare in England. So health is a devolved concept. So most of what we're going to be talking about in terms of finances is to do with healthcare in England. Scotland, Wales and Northern Ireland determine their own health budgets based on any money they generate in Scotland, for example, and their allowance they get from the government. So health gets nearly just under 200 billion pounds. So with a billion with a B, billion pounds of money every year. Education gets in the region of 90 billion pounds, and defence gets just over 50 billion pounds. So you can think that, and so, Ministry of Defence has had significant cuts, but it's never been anywhere close to health. And people say, oh, what about the aircraft carriers? What about the nuclear deterrent Trident? Well, that money is spent or spread over like 20 years. Okay, so even if they're multi-billion pound projects, that's spent over 20 years or so, the lifetime of the aircraft carrier or of the Trident missile system. So what we've also noticed, so this is from a few weeks ago now, is that spending on healthcare as a proportion of all day-to-day public service spending is going up. And so we're at a point where just under half of all public day-to-day public service spending is on healthcare. So whichever government gets in a few weeks' time will have a challenge to both increase spending on healthcare, but also maintain all the other public services. So just we are in a very difficult financial climate, not just within the NHS, but just nationally. So the most recent budget, they committed to an extra nearly 2.5 billion of revenue day-to-day spending, and and 3.4 billion of capital spending over 3 years from 25-26. Now, again, that may change because that may be adjusted either up or down depending on what happens at the general election in a few weeks. So if we look at the split, so this is just an idea of how things have changed over the last few years. The majority of the health budget, so this is the whole bar is the health budget. The majority goes to NHS England. Okay, so when we say the acronym DEL is Departmental Expenditure Limit, they're the kind of nominal expenditure caps that the different areas have. Okay, so most of it goes to NHS England, which is the orange. The grey is the capital budgets, which are kind of relatively static. And what has been happening pre-pandemic and then a little bit this year, or last year, was that when the providers overspend on the revenue budgets, they have to raid the capital budget to kind of make ends meet or make the numbers add up. So one of the reasons why we've been struggling for capital money is that we've overspent our revenue budgets, and so we've had to take money from the capital budget in order to do that. The blue bit at the beginning is just for the Department of Health and Social Care itself and its services that it provides. Now, it looks like it's a lot of money, but from that blue bit, it has to fund a number of organisations. So there are, if we exclude NHS England, there are 10, 11 different organisations the Department of Health and Social Care has to fund.
Add them to the chat. I think we've kind of run out of time for any more questions, if that's okay. But we really thank you, Georgina, for sharing that experience with us. And as always, a very sort of interesting topic that generates a lot of debate and will continue to do so, I'm sure. So we're going to break for lunch now. Hi everyone. So I'm hoping that we're ready to start our next session. I'm just going to see if our next speaker, Stephen Lee, is available. Just give it a few more moments.
I'm present and correct, Pam.
Oh, fabulous. Lovely to see you again, Steve.
And you. You caught me a little bit off guard then. I thought I was on at 1:15, so...
Oh, bless. That's all right. Are you ready? Are you okay? Are you okay to begin in the next couple of minutes?
Yeah, I think we're good to go.
Yeah, that's brilliant. Our session just before lunch ran over a little bit because it was such an exciting topic. We had lots of questions. I think people are still joining, but whenever you're ready, Steve, while you're getting set up, I'll introduce you. So we'd just like to welcome Stephen Lee, who is the Head of Finance at University Hospitals Leicester NHS Trust. And we used to work together, very much so, on PLICs and costing. And Stephen's done a fabulous job of taking the whole engagement with clinicians forward through their patient level costing system. So when we're ready, I'm going to hand over to Steve. Thank you very much.
Lovely, thanks, Pam. Just hopefully you can see the slides okay there. Please feel free to shout up, ask any questions. Unfortunately, I'm just on a single screen thing today, so I can't see any hands up, but I am more than happy for people to just shout out if they've got any particular questions or anything. So as Pam said, I work at the University Hospitals of Leicester NHS Trust, and I've been doing costing for probably the last 15 years or so. So hopefully a dab hands it now. I should be able to answer any questions if you've got any. So I'm just going to talk to you a little bit about what is costing, and in particular PLICS, or the patient level information and costing system, why that is important to you, or hopefully important to you, a bit of the detail around that PLIX system, and then how we use the data as well. So what is costing? So the kind of technical, boring, blurby definition is that it's the quantification in financial terms of the value of resources that we use when carrying out a particular activity or producing certain outputs. So within the NHS, particularly the acute setting where I am, that's the cost of delivering our clinical services and specifically the individual patients that we treat. We'll talk a little bit more about how we cost those individual patients and those services as we go throughout the presentation. So as we've already mentioned, the PLIX element or patient level elements is kind of a two-part process for us here at Leicester and across the country. So the first part is that there is a national requirement for the annual collection of our costs, which we're just in the middle of at the moment. And there are a set of national standards that we have to adhere to for that. It's really important that we do that. We try and do it as consistently as we can across organisations to give the wider NHS the information that they need. But probably more importantly for us within this organisation, and hopefully more and more organisations as they continue to mature in the PLIX environment, is that it gives the organisation a really valuable tool to look at how they use their resources, where they use them, and how they might use them more effectively and efficiently. Again, hopefully that will become more apparent as we start to get further through the presentation. One of the key things that we get asked about is why PLIX is so useful, and don't we have all of the information that's contained in PLIX in various forms across the organisation? And I think we do, but there are very few places where all of that activity and cost information is combined to give you a more holistic view of how you use your resources across the organisation and how productive you are. So this is a little bit of a busy slide, but a lot of people we tend to talk to are very familiar with traditional financial reporting or the budget management, financial management aspect of things. So it's just a bit of an illustration in terms of how what we do in costing, both at a patient level and a service level, varies to that traditional financial management. So the first big thing is that we do not look at budgets. It's solely around the cost of delivering our services, treating our patients, and comparing that to the income. So we scrap budgets, not interested. We think it's much more important to look at your performance against the income that you generate. And we try to give a whole view of the cost of providing those services as well. So within traditional financial reporting, you tend to see a set of cost centres that might be specific to the use of one resource. So you might have a set of ward cost centres that are managed by your sisters on the wards. You might have a set of cost centres that relate to theatres, other ones for support services and that kind of thing. What we do is pull all of those costs together in terms of the resources that are used for particular treatments, for the running of those services, and bring that all together regardless as to who manages the budgets and the cost centre finances. So we give a whole view of those costs. In the example that we've got on screen here, that just kind of gives you a bit of an illustration in terms of how those two reporting mechanisms can show you very different results. So in this example, we've got vascular surgery at the top of the screen, who have planned expenditure of 4.5 million, actual expenditure of 5 million. So they have a loss or a deficit on there of £500,000. For their income, they have planned to generate 6.4 million, but have generated more than that. So overall, we see a surplus against vascular surgery in the traditional financial management reporting that we have here at this organisation. If you scrap those plans and you just look at the actuals, and then you add in the additional costs for the support services, theatres, trust overheads, and things like that that are all needed to treat those patients within vascular surgery, we actually see that the cost for treating those patients goes from that original £5 million for their direct costs up to a total fully absorbed cost of £9.2 million. And their income increases slightly as well because we give them a fair share of the trust-wide income that we receive for other bits and bobs. So their direct costs and their cost centre reporting would suggest that they have a slight surplus against plan. In reality, when you look at a fully absorbed position, we say that they've got a £1.3 million deficit when you compare their spend to the income that they generate. And that tells a completely different story. So that's one of the differences that we have. In the interest of time, I'll just whiz through this really quickly. I'm pretty sure that everybody on the call is fully aware of the financial challenges that are faced by the NHS at the minute, and a quick Google can go on to give you more information about the financial pressures that we have within the organisation and some of the ways that we might look to improve that, like reducing unwarranted variation and the likes. So huge stresses and pressures. I don't think any organisation will be able to meet their current cost improvement programme targets without starting to get into some of the detail that patient level costing and service line reporting can start to shine a light on. So how do we do it? It's a very simple view of how we do it, but there are a few key elements in terms of pulling all of the data that we need together to give a fair and accurate representation of how much it costs to treat our patients and run our services. So the first part of that is understanding our patient journey and how it's recorded. So we bring in information from a huge number of different patient activity systems, support service systems, things like that, to try and understand as many things about those patients and how they've been treated as is humanly possible. We then need to understand our general ledger where all of those costs are recorded, and we need to build some relationships between the two. So as you can see from the kind of cogwheel chart, there's a couple of elements to it. So the first part is for us to understand what patients come through our doors at the hospital. So we receive a number of feeds that tell us what inpatient activity we have, how many outpatients we have, who those outpatients are, what A&E attendances there are, and a few others like renal dialysis, radiotherapy, and some other bits and bobs where they're not part of the reported through SOS. Alongside those patient attendances, we bring in the ledger costs. So all that work that financial management do and have reported against their cost centres, we pull that data through. We then go on to a second stage where we try to understand what are the drivers of those costs to those patient attendances. At a very simple level, that can be things like what patients have stayed on what wards and for how long. It might be how many patients have we seen in theatres, who were they treated by in theatres and how long were they under anaesthetic for. And then we start to get into some of the high volume detailed information around what pathology tests they may have had, what imaging exams, any other diagnostics, what drugs have they been issued, what devices and high cost consumables have they had. put into them or used on them during their treatment. There's a whole host, and I think at Leicester we bring in about 40 different information sources to tell us about the different things that might drive the cost or the resources that have gone into those patients. We link all of that together by talking to our services and our financial management teams to try and understand how the costs in the ledger reflect those activity sources, and it's all kind of churned through a big sausage machine, which in the end gives us an itemized bill for each patient that comes through the door, by taking those activity systems, linking them up to the ledger costs, and giving us basically a breakdown which will show each of those elements in the kind of chart we see on the bottom left hand side here. We report that against the corresponding income that we receive. If you've been spoken to today about how funding flows and things like that, it can be a bit tricky where we have areas like block contracts or the aligned incentive kind of agreements that we have. So what we do is, particularly here at Leicester, and it may be similar across other organisations, is show what your income would be if you were paid tariff, just to give a bit of a benchmark and something to compare against. So all of this data is underpinned by activity data, and we can start to aggregate that then at various levels to show where we have variation between the cost and the income, where we might have particular areas of opportunity, and then where we might start to see things like clinical variation within services if there are certain consultants that treat their patients in different ways. What does that look like? It can look different depending on the system that you use, depending on the dashboards that you've deployed, and things like that. But as a quick illustration, we can see that information then, as I say, at varying levels across the organisational structure. So the two illustrations we've got here, I'll start with the tables. So this is for a particular service. I think it was cardiology or cardiac surgery. We can show an overall summary for that service with how much activity they undertake, what the total cost of delivering that service is, and what that income would have been if we were still on a payment by resource kind of payment mechanism, and what the theoretical profit or loss is for that service. So you can see in this example we've got a significant loss. One of the levels we can aggregate to is HRG code, but we can go down to things like procedure code, diagnosis code. We can look at it at a consultant by consultant basis, and we can start to drill into it to see where that £4 million loss is. And as you can see in this example, there are 5 HRGs that make up probably 45% of the loss within that particular service. We can also show those ones that are particularly good or profit making as well. The bar charts that you see in the on the left hand side is an illustration of a particular patient's cost. So not only can we show an itemized bill for the types of resources that each patient has consumed, we can plot that over time because we cost on a daily basis. So in this particular example, you can see that a patient has stayed in for a significant amount of time, 35 days, and we can see the spread of the resource consumption for that patient as well, which can give you a really good insight into where you're using resource within that patient journey, and start to look at whether there are patterns across patient cohorts and things like that. So we can put together some really pretty charts, and we can give some information about which services are performing well or not performing well against income. But I guess the question you're all here for is, how do we then use that data? And we've got a few kind of insights here in terms of how we might be able to use that data within our organisations. So for me, one of the most fundamental things is that it starts to give us an understanding of what our economic drivers are. What is it that causes us to spend the money that we spend, and how can we kind of make that more transparent? So getting this data out there gives a real insight to managers and clinicians to understand where their resources are being used, how they're being used, and what drives their cost. So that's great, and that's something that traditional financial reporting doesn't tend to do. We can then start to, as we've already touched on, is start to identify differences in practice. So that granular level detail about what patients consume, what resources, can allow us to start looking at the way that clinicians treat their patients and whether there are differences in the way that certain clinicians treat their patients compared to their peers. You can go right down and you can start to look at things like whether they prescribe the same types of drugs, whether they request the same number of diagnostics, have the different choices in the prosthesis they use, whether their length of stay for those patients are higher or lower than their peers, whether they take longer in theatres and have kind of more costs because of all of those different elements. At this point in the conversation, when we're talking to services and clinicians and managers, we think it's really, really important that we highlight that just because there may be some consultants that are cheaper than others, that's not necessarily then the right thing to do and the right way to work, and that everybody should do it in that way. We use this data to highlight those differences in practice, but always ask that people consider the vast number of other metrics that are out there that tell us about how successful we are with the treatments that we undertake, what's the quality of the care that those patients receive, because ultimately that's what we're here for at the end of the day. In the data that we produce, we do it at an episodic level. So it might look as though consultant A is much cheaper at delivering that activity than consultant B, C, and D, but actually he could have significantly worse outcome measures and things like that. He could have higher readmission rates, which mean ultimately the total cost for treating those patients may be greater. So it's really important that we take those things into consideration as well. Those differences in practice kind of can go a little bit wider in terms of the benchmarking that we do. So we do a little bit of the internal benchmarking between consultants, but we can also compare ourselves to other organisations across the country, whether that be a national average or specific peer comparisons, because all of that data that we produce goes off to NHS once a year. And at some point in time, we get those results back. We're still waiting for last year's data, but in theory, we can benchmark against other organisations to see whether there are specific practices at your organisation that are delivered differently to those elsewhere. We can also use the data to help inform tariff setting. So a big part of the tariffs that we receive and the payments we receive are kind of mandated nationally, and all of that information is kind of compiled on the back of some of these costing returns. So more accurate costing data will hopefully lead to more accurate tariff prices. But we do also use costing data, especially here within our patch, to negotiate local prices. So there have been examples where we know that the locally agreed tariffs haven't covered our costs, and we've been able to evidence the costs that we incur for some of those things and renegotiate tariff prices. So it can be a useful tool in instances like that. We can also use some of this costing data to help build business cases. A lot of the time, our services are able to kind of talk about the expected changes and perceived benefits to patients, but aren't able to quantify them in financial terms because we cost pathways across the organisation, and we know the drivers of those pathways. We can hopefully help people who are building those business cases to translate those changes into kind of pounds and pence and the benefits that we might be able to deliver to the wider health economy using some of that information. And we can also start to track performance over time as well. So I think historically, a lot of people have used costing data to look at how your cost compares to your income. What certainly, again, we've started doing locally is start to use that information to track model hospital style metrics, like your cost per weighted activity unit over time to see whether your services are becoming more or less efficient, and start to quantify the value of opportunities in terms of productivity opportunities, and highlight those areas where we think there is room for improvement. There's a few challenges for us, and I know this is probably the case for pretty much every organisation across the country. Costing teams traditionally tend to be quite small within organisations compared to the rest of finance, and yet we have to understand both the cost base for all of our services, the activity those services record, and the way that they undertake their services to link all of those things together. So it's a real challenge for us to understand those services, get the data that we need to accurately reflect the costs of delivering those services, and to engage with clinicians and managers in order to use that data. So we kind of look to you guys to help us along that journey. So as it says here, you are all key stakeholders. You will all have probably a really good understanding of specific elements of the care that we provide for our patients. You'll also have the influence and ability to change how we provide those services and meet the needs of our patients. So it's really key that we engage with you, work more closely with you, both to improve the accuracy of the data that we provide, and also to then work with you to support decision making and improve outcomes for our patients at the end of the day. One of the areas that we get a lot of traction from with speaking to our clinicians is not by highlighting areas to our clinicians, but working through some of the frustrations of our clinicians around blockers in productivity or efficiency, and helping to illustrate those to then put forward a case for change. So we would encourage everybody to link in with your costing teams and look at how you can improve and use your data. Just to touch on that again, really, here in finance, we are most definitely not experts in caring for our patients, and in most instances you guys are not experts in NHS finance, but I think if we can work closely together, then the outputs that we can provide can really help to improve the quality of care delivered, and the kind of productivity and efficiency agenda of the organisation. So hopefully most of you guys on the call hold the key to understanding how we consume our resources and can tell us that. You'll also know what data is recorded on the shop floor and how that might relate to the care that those patients receive. And as mentioned just now, you'll probably have a feel for where processes could be improved and things like that. Hopefully we can then help to evidence or disprove some of those hypotheses. We can help to identify new areas of opportunity, and we can help to shine more of a light on those things by pulling together that range of information that's not usually all available in one place and linked together. So a couple of tips and takeaways if it's piqued your interest in PLICs at your organisation. It does take time. and your resource, but usually if you can invest a small amount of time and resource into looking at the data, discussing it with your finance and your transformation teams, the benefits will almost always outweigh the cost of doing that. So we strongly encourage you to do that. Please engage with those costing professionals and other finance colleagues within your organisations, depending on the setup of their teams. There is a huge amount of information that's produced for both the national returns and business as usual PLICs. Hopefully that can be of use to you, even if it isn't perfect. It's usually good enough. If there are any people out there that are in management positions or finance positions on the call, I'd encourage you to focus on what's important to your clinicians in your organisation to help engagements. And lastly, there are some really, really good networks and organisations out there who share best practice, more training and development on subjects like this. So the HFMA, One NHS Finance, usually there are people in those networks who've come across some of the issues that you might be facing or wanted to look at the areas that you're looking at, and that sharing and use of knowledge and information across organisations can sometimes really help you take things forward. I think that is about it for the slides. That was a whistle-stop tour, because I think I was asked if we could squeeze it down a little bit to fit another presentation in. So I guess I'll just see whether there are any questions out there.
Thanks so much, Steve. Always interesting to see the world from a patient level costing perspective. There were some questions in the chat, which I think I've answered through the chat. There was one question from, I think it's Nigel Willoughby, wanted to know what SUS stood for.
Oh, crikey.
That's what I thought, crikey.
I can't remember off the top of my head what it stands for. So when we
Sorry to throw you in
no,
there.
no, that's all right. So I can explain what it is. So it's the kind of nationally mandated activity returns that will go off to NHSE. But yeah, sorry, I can't remember what the acronym stands for. I really should know that.
We'll find out and put it in the chat, so don't worry.
Absolutely.
No, thank you, that's fine. I just wanted to make sure it was what I thought it was, because people are great at using initials and then they go, no, it means something completely different. So that's what it was, but thank you.
Brilliant.
No worries.
I think, yes, I think we've answered all the questions, and in the spirit of getting us back on track, and I'll just check whether our next speaker is available. I think it is Claire Jacqueline, who's going to talk to us about costing and PLICs in mental health. Oh, there you are, Claire. Fabulous. Fabulous. So we'll say a very big thank you to Steve for joining us and sharing his expertise. And I'm sure we'll see you again very soon. And if you do have any more questions, just pop them in the chat, and we'll do our best to answer those as we go along.
Yeah, I'll hang around for the next 15 minutes or something just to answer any questions.
Thank you very much, Steve. And
cheers.
So we'll just welcome Claire, and who's a senior costing accountant at the Humber Teaching NHS Foundation Trust, who's going to do a similar talk, but from a mental health care perspective. So thanks for joining, Claire. I'll hand over to you now.
Hey, can you hear me fine?
Yes.
Brilliant.
Thank you.
I actually can't see the chat or any questions, so if anyone wants to put any questions in the chat as we go, I'll try and answer them at the end. We're kind of running behind slightly now. Right, so my name's Claire Jacqueline. I'm the senior costing accountant at Humber, which sounds probably more official than it is because there's only 1.85 whole-time equivalent and a gentleman that works with me running our costing show. I firmly believe that you can cost anything with the right information, but that information does not have to be perfect. But there needs to be a reason, a purpose, a so what. Why are we doing it? There's always a trade-off between time and accuracy in what we cost. But if we use the information, it tends to highlight issues and helps to affect change for the better. So my session is going to just give you a whistle-stop tour about what Humber Teaching Hospital Trust does, what is costing, why we cost, costing in a mental health provider because it's slightly different to those in our acute or ambulance peers, understanding patient level costing and how costing information can improve our patient care. So as a trust, we cover an area of what, 765,000 people over 4,700 square miles and across age groups, all age groups. And today I'm going to concentrate pretty much on the community and mental health inpatient services and not any of the other services that we run as well. Yeah.
Sorry, I'm just gonna. I think there's a few people that are saying that the sound was a little bit low. I don't know if you're able to turn the quality
Okay.
sound
Can you
upon
hear me
your.
any better now?
I can hear you fine. I'm hoping that others can as well. So might be a case of, oh yeah, got thumbs up. So maybe speak a bit louder. Brilliant.
Yeah, no, it
Sorry
depends
to
on where my
interrupt
laptop
you.
is. I do apologise.
That's all right. Sorry to interrupt you there. Carry
That's
on.
okay.
Thank you.
We have about 3,800 staff, around 80 sites. So where the acutes tend to have a few sites, we're spread all across the counties. We are a teaching trust as well. So we work closely with Hull York Medical School and the University of Hull. And we do things like research and development. And in terms of turnover, we're very small compared to the acute hospitals. Our turnover is about 250 million. But from a costing team perspective, we still cost around 180 service lines and will have cared for about 75,000 unique patients last year, which is about 10% of our population. So costing, the definition on the internet is the proposed or estimated cost of producing or undertaking something. And in terms of, for the NHS, costing quantifies the financial value of resources consumed when we are carrying out an activity. So resource examples could be your nurse, your occupational therapist, your psychologist, etc. An activity for us would be a lot of activity in the community care setting. So we may go to patients' homes, or we may do group activities or contacts. We obviously have bed days where patients are admitted onto wards. We do a lot of supporting activity. For us, costing is not all about just the contact, because we have to liaise with things like schools or the police or with other specialties quite a lot to make sure we're providing the special care that each person requires. And so we look at the time it takes to do all of those things and not just the face-to-face delivery or telephone delivery of care to patients. So why do we cost? Well, obviously the NHS is a public funded body and we need to explain how we are spending the money, and lots of stakeholders have different needs for that money, whether that's our local ICB or whether it's NHS England wanting to see whether they're spending the money, or the regulatory bodies. We have a lot of stakeholders, and particularly the carers and patients want to see what we are doing and able to deliver. Why do we cost? So we can use the information to make more informed and evidence-based decisions around the people we employ and the skill mixes of those people, the places that we deliver care in, because that can be key in mental health. Some patients' illnesses will not almost allow them to go to like big hospital sites. It's a scary place for certain patients with mental health illnesses. So it's where we deliver the care and how we deliver the care, and also what services we do deliver to the patients to support the populational need. Why do we cost? My first question, although I'm not actually going to ask you to tell me what answer that is if a team A spends 10,000 less than their budget, but team B spends £10,000 more than their budget, which team is doing better? And my financial managers probably look at budgets and budget statements and use this information a lot. But from my perspective in costing, this doesn't give me enough information. I don't know whether just because somebody is spending less than somebody else, whether they are delivering a better service or not. The same question really, but I've now started to get a little bit more information on there. So here Team A is still spending £10,000 less. No, Team A is spending £10,000 more than their budget. Team B is spending £10,000 less than their budget. But I've now added the number of contacts there. And so Team B is cheaper per contact than Team A. So which team is doing better now? And from my perspective, again, we still don't know the answer. I can't tell from that information whether one team is doing better than the other. There's no information in it around how long each of the contacts were. And actually, even if the one's team's average contacts were longer than another, it doesn't necessarily mean for a mental health patient that is better. And there's no information there about the interventions received. And particularly, there's no information around the outcome of those contacts. Have we made a difference? Is the patient happy with the level of care that we are receiving or providing to them? So why do we cost? Obviously, the NHS is a public funded body, and so we need to understand if we are providing value for money. Kaplan Porter did a lot of work on this, and so they sort of said that health outcomes achieved that matter to the patients relative to the cost of achieving those outcomes is the value that we do. Are we making a difference? Another reason why do we cost is to understand if we're providing care fairly and in addressing any of the health inequalities. So the health inequalities are unfair and avoidable differences in the health across the population between different groups in society, depending on where we've been born and brought up, where we live, where we work, what age we are, and they all influence the way that our mental health is, how we feel, how we act, and our physical health and well-being. So things, characteristics may include the socio-economic things like status of unemployment, low income, people living in deprived areas where they've got poor housing and poor education, or it might be protected characteristics around sort of age or sex or sexual orientation or disability. There's vulnerable groups where you may have gypsies or travellers or rough sleepers or homeless, and the health status and life expectancy of these people may be affected by the care that we deliver. And also their access and availability to care that they go and view and see and are able to access. So in our costing system, we have information around the level of deprivation of our patients based on their postcode, based on national government information. Here I've got two teams which are community mental health teams. The team A on the left is in a more deprived area than team B on the right. So the decile score across the bottom, decile 1 being the highest level of deprivation for the index of multiple deprivation I'm using here, and number 10 being the least deprived areas. And so I can add cost information to that, and looking at that at quite a high level, they look to follow a similar sort of profile in the cost to the number of patients that we have. But when I add things like the average cost per patient by decile, if we're offering a fair and equitable service, these teams should have a very similar spend across all of them. If not, we would expect that cost to go up slightly as they become more deprived because they have more factors of complexity related to that care. So team A probably does that slightly. It's a similar sort of slightly upward line. But team B, I seem to have an issue in the fact that deciles 3 and 4, we're spending a lot more than on deciles 1 and 2, which are my most deprived areas. And so it asks a question to me as to why are we not able to care for those patients in deciles 1 and 2? Are we not offering the service to those people in that right area of in that area of care or in that locality? What's the barrier of entry for those patients to be receiving our services? So having the information allows you to look at what you deliver and how you deliver it. As I said before, you can cost anything with the right information, and we cost everything at the most granular level, every contact, every bed day, every drug, every supporting activity, but the data isn't perfect by any means in our system. We do not have actual contacts recorded in a ward setting, and so use the clinical notes recorded by staff member against each and every patient as an estimate. It's not perfect, but it does give us some information. So now I've got two charts up. The chart on the left tells you the average cost per occupied bed day in one of my mental health assessment wards. And the first 13 patients on that chart do not equate to the most expensive patients in the chart on the right. The ones on the chart on the left all have bed days less than 5 because they're all in a part of the assessment process, early assessment process after being admitted. And if we didn't have costing information, without using the clinical notes information, the cost per bed day would have been the same no matter what patient, and it would have just reflected the most expensive patient on here would have been the one that was the longest in a bed, but that actually isn't the case in our units. So here the person that had been in the bed for the longest length of time was the 5th most expensive on that ward, not the most expensive, but we just used a different data set because we don't collect contacts on a ward. So you can cost anything with the right information, but we do have lots of difficulties in costing mental health services. One of them being the accurate recording of data to report on costs with. The acute trusts had payment by results for a while and clinical coders, so they were able to get very good at coding their information that they have. And the other difficulty in mental health is grouping and categorizing what you are costing so you can make meaningful comparisons. In mental health, people are kind of hard to box. It's quite difficult to always group people together, and groupings have changed through the national tariff or through the national framework over the past few years, moving from clusters to mental health resource groups. So it is changing. The clusters has been scrapped. The new currencies are being developed. And this is just a slide that I've stolen from NHS around the new currencies and clusters, but it's still a work in progress. These boxes and categories and currencies are not set like the HRGs are in acute services. But we are trying to get our own house in order around mental health currencies. They're looking at things like complexity factors to break down the level of need in each of the new currencies that they're devising, using data that we already collect in our national data sets. Things around accommodation status, age of client, deprivation, employment, ethnicity. And I'm trying to look at whether we have those data fields already populated in ours, just to try and get ahead of being able to categorise how we group our patients, so we can do comparisons within ourselves and in the national cost collections, so we can do benchmarking and that going forward. But it's still a place of development by NHS. So the final difficulty in costing mental health is measuring and costing outcomes. Have we made a difference to the patient? There are a different number of outcomes: patient-reported outcomes, clinician-reported outcomes, and patient-reported experience measures. It's not consistent, and I don't think there's a national guidance on which should be used in which service for which group of patients. Trusts use different versions of these things. So you might be, for say, a PROM using something like recovering quality of life, REQUAL, or you might be using goal-based outcomes, or you might be using dialogue. these are all different tools for rating the quality and life experience of care that you receive. So comparing outcomes, and certainly in my costing system at the moment, we're very much about counting the activities and who has seen which particular patients and that sort of care that's been delivered, but we're not as good at reporting whether we have made a difference. And obviously with mental health patients, some of them may be with you short term, but some of them may be with you for life. Pay in our trust makes up around 80% of our total costs, and I've seen a few methods used to calculate pay. One simply being the total pay cost divided by the total activity. But there is a disadvantage to this method with low recording of activity. So if a staff member records one patient activity before going on sick with full pay, the cost of that staff member would be allocated to that one patient's activity, overinflating the patient's cost. It's not something we use. It's simple, it's quick, but it doesn't always give you the best costing results when in a mental health situation. It may very well be one staff member going out to see a patient. It's not a team, and so the cost can vary very differently depending on the grade and type of staff member gone to visit that patient. We use the second method of allocating pay, where we work out a cost per minute for pay. So each time a staff member records time of delivering care or working on a patient's care, we allocate a number of minutes to each of those minutes that they've a cost to each of those minutes recorded. So it allocates an actual amount of cost to the care that's being delivered, but it doesn't allocate full pay costs for anybody, because nobody really records 100% of their available time. People need to have a wee break or a cup of tea, or maybe go scream in a cupboard if it's got a bit stressful. We don't expect anyone to work 100% of their clinically available time. And then anything that is left over, we allocate to the activities of the team. So we think it gives a fair reflection of what cost has been provided to a patient when a staff member or somebody records low activity, but it also allows us to compare and monitor staff being as a level of resource usage. So of their available time, how much time are they actually recording clinically, so we can compare staff members. If staff member A and staff member B are in the same team and meant to be delivering the same level of care to patients, why do I have a difference between staff member A and staff member B? What is stopping staff member A from delivering more care to patients, which ultimately we need to free up our staff to spend time delivering care with patients to make them better. But the main disadvantage of doing a slightly more detailed costing is time and effort, both to collate the data and to calculate the results, because the more complex your costing model becomes, the slightly slower it gets to compute. So it can become a bit more burdensome if you're a small team. On this is just another way of looking at the clinically available time. There are slight flaws to it, because I don't know if you can see clearly on this team, I've got a staff member here, staff member G, and in April they recorded 103% of their available time, but in May it drops down to 75%. There's a slight timing issue that we have there in the fact that when activity is recorded in the patient administration system in April, they have probably worked overtime, but the overtime pay wouldn't hit until the May. And so I get a slight imbalance between the 2 months. It works itself out over a period of time, but it's something that we use to compare staff members and try and understand why we have differences between team members when they are delivering different levels of care. The staff member A at the bottom actually might, at 28% of their available time, be a great staff member. They might have quite a lot of managerial time that they have to do with that team. But when managers look at this information, that they obviously know who each staff member is. I've quite scruffily scrubbed the names out so you guys can't see who's who. The other information that comes out for us, we've spent quite a bit of time looking at DNAs, because if we're going out to see patients, we hope that they're going to be there. We don't want the big cost of driving up to, say, Scarborough from Hull, to find that the person's not there. So I can see in here, I've got 3 staff members with activities where they've recorded an average duration that is quite high for a DNA, because the aim for the contact with the DNA is if your client doesn't turn up, that you move on to do something else. We also look at staff time spent travelling in the table below, where I've got staff member M spending 31% of their time travelling, but D only spends 8.9% of their time travelling. So does M have an issue with the way that they organise their routes to visit clients? Is there something that we could do better, or is it purely that that team is spread across a diverse and wide area? Or should we be looking at different locations and for teams to be based from? There's different things that we should be looking at. I know I mentioned that pay makes up the largest part of our costs, but we do allocate other costs to our patients, things like estates and capital costs, where we use things like meters squared or time used, HR and payroll costs where we use actual whole time equivalents and things like that. But there is a nationally approved costing guidance technical specification that tells us how we should allocate each of these overhead costs to each service line. So we follow those rules. And this is a pictorial representation of a patient's journey in one of my divisions. It's by costing at a real granular level, you can add things back together and start viewing journeys, and these, each coloured line is a different team. The patient here cost us £132,000 in year to treat. They saw our GP services, they saw our community mental health teams, our community mental health physio, crisis and psychology teams. And eventually, unfortunately for this patient, they required an inpatient admission. The patient themselves progressively got worse. They were a child that was on the start of their journey that rapidly got quicker. Probably shouldn't show that one, but it demonstrates the information that you've got, and you can see who is involved. We can see this data in a number of ways. So I can see it whether in the first chart, whether it's a face-to-face GP, non-contact activity, which is things like our MDTs and clinical notes and administration and that sort of stuff, occupied bed days, telemedicine, telephone. So I can see the different types of activities and the profile of that across the months. I can see it as a patient bill. I could look at it by location. I could look up to whether we've travelled. I could see what staff are involved in the care. I can see it in any particular way that we slice and dice it, because we have the detail built up beneath it. And it allows you then to start comparing similar teams. So on here, team 1 has the highest average cost per contact, but actually when you look at them, they have the second lowest average cost per patient. So what does that mean? Is what they are doing, and when they're delivering care, something better than the other teams when they're all delivering or meant to be a similar type of team? Team 1 is also attracting the highest level of home overhead, and team 4 is the lowest. Is this caused by the base, the location, potential errors in that we've allocated? Everything that we've got in our costing system is still a work in progress. It requires people to look at it and to point out strange things, so we can learn together. I currently on these charts in my dashboards have the average duration of a contact missing. So I don't know whether the lowest average cost per contact team is just delivering shorter contacts and not activities. Activities for us includes the non-contact supporting activities, which wouldn't for a national cost collection be included. So how costing information can improve patient care. Costing information is not perfect, but the more it's shared and reviewed, the better it becomes. So there's been improvements in our own internal processes. We've had issues with data entry validation, and we've looked at that. We've concentrated on DNAs and highlighted those that are having significant travel time. So we've been implementing, making sure that staff ring before setting off to reduce wasted time. We've reviewed the care given to some patients. So we had one of the teams spending quite a lot of time and activities with certain patients within it, and that team was meant to be fairly low need. And so those patients were reviewed and signposted on to a more suitable service, given the frequency and high volume of their contacts. We've looked at the guidance on how we record our data, because there was differences in what staff member A was doing to staff member D. Some of the glossaries and standardization was not particularly clear. And so we went through a series of rewriting training and guidance as well. And there's quite a lot of focus at the moment in my trust around capacity, demand and productivity. How much time do we have to deliver care for our patients, and are we fulfilling that potential? And then it also allows us to explore clinical variation and practice across teams. If teams are meant to be delivering similar things, we can compare and contrast them and learn from the best. So improvements in patient care, also it enables you to make those comparisons, to see the variations and highlight any potential areas of practice or good practice or concern. And it allows you to review the patient journey for planning purposes. I know in the past we had things like dementia campaigns, and suddenly got a lot of new referrals through with people asking to be checked, because people became more aware, and you can then start planning your resources and whether you are able to meet those needs, and have discussions with your own ICBs around that sort of thing. So the data can be used by the ICBs as well, allowing them to plan for spending, and it allows us to focus on our productivity, to see areas of overlap, duplication, and to streamline. It does allow you to work with other organisations to improve patient care. We did a piece of work with our acute hospital, looking around the cost of frequent flyers, those turning up at A&E regularly, but with a mental health rather than a physical health care issue. And we've put some steps in place to try and alleviate that and make sure that the patient is seen in the right place at the right time. So I suppose, any questions?
Thanks very much for your talk, Claire. That was really, really insightful. There haven't been any specific questions other than I think Noreen was just questioning the accuracy of the self-reporting around the time usage of staff. I think that was the only kind of relevant question in the chat. If you wanted to talk about that quickly.
Because in the EPR, the staff member records each of the times that they spend with the patient and either actualize that contact or DNA or whatever else. We just pick up the activity data that they've recorded. If they don't record it because they are too busy or whatever else, there is no evidence of they've done anything, and that is something that's highlighted and managed by the teams. We did have an instance once where we had a staff member that worked in more teams, but this showed that they actually weren't recording in either of those teams, and that became a disciplinary issue. But it isn't about kicking a staff member, it's about understanding what we do and how we deliver care, and how we can learn from it to make things better going forward.
Thanks. Yeah, I think you're right. It's not always about what the numbers say, but how is it signposting us to improve and perhaps correct any anomalies either in the service or the data. So that's really, really helpful.
Yeah.
So if there's no more questions, I'm going to give Claire a very big thank you for spending some time with us to talk about patient level costing in a healthcare setting. I'm hoping that everyone is able to hear me at the moment. I know we had a little bit of problem with the sound earlier, but I'm hoping that that's fixed itself now. Brilliant, thank you. So I'm going to see whether our next speaker, Richard Sawyer, is available.
Yeah.
Hi, Richard. How are you doing?
Hi.
You good?
Yeah, really good. Yourself?
Yeah, very well, thank you. Having a fun day learning all about demystifying finance.
Fantastic.
That's great.
Hopefully I'll add to that.
Oh, yes, fantastic. Yes, we always look forward to your talks about Evo. So Richard is a senior program manager at One NHS Finance and is going to tell us all about the Evo program. So whenever you're ready, Richard, I'll hand over to you. Thank you.
Fantastic. Thanks very much. Right, so I'm just going to put up some slides and talk through for the next sort of 20 minutes or so on Evo, and as the agenda suggests, what is it? So I'll probably do about 10 minutes giving you a bit of an overview, and I'll use the analogy of space to describe that because we're going to have a bit of fun in the next 10 minutes. And then the second sort of 10 minutes will be centered around giving you a bit of an idea of the tools some people who are implementing Evo in their trust will be using. It's going to be quite quick, because usually this deck is about an hour, so bear with me, and I'll make sure all these slides I don't get to are distributed after. Right, so if you just give me a shout when you can see my screen, that would be really helpful.
Yeah, that's great. We can see you.
Lovely. Thank you very much. Okay. So, in short, what is Evo? So, I mean, the ultimate goal of the framework itself is to help teams improve patient care at the system level. And it's done by supporting evidence-driven, value-based decisions at the specialty and service level. So the framework itself is a free of charge physical project management handbook about this thick, and essentially NHS, it's open to NHS trusts, and it will be posted to those trusts on completion of a successful application when they submit it. So this application basically requires the medical director, the director of finance, and the trust board all to sign a commitment statement for Evo. And what that does is it protects time for the team that will learn the methodology and deliver that methodology to do this. So essentially, the handbook itself is delivered by operational, project management, and costing staff, all taken from existing staff on site. And essentially, they will be able to evidence the need for change using the available PLIX data. Stephen and Claire have done a great job of summarising that PLIX data for you, so I don't need to do that. I mean, the thing to know about the Evo framework is there are no external parties involved in the process at all, and trust teams are empowered to basically make decisions, implement changes, and for the first time, they're able to measure the impact of their clinical transformations that they make using value. And hopefully this presentation will articulate what it will, show you how that's done. I just want to make clear that the focus of the entire framework is firmly on prioritizing the health outcomes for patients using the resources available. Okay, so you'll recognize this as the value equation, or at least one of the many value equations you will have seen in lots of presentations. And value, as we know, is defined in many different ways. And as a result, it's actually regarded as a concept or theory of measurement rather than an actual measure itself. So what Evo does is it simplifies value, allowing teams on the ground to use it as a practical and tangible measure of improvement. So value for the purposes of Evo is defined as outcomes or quality relative to costs or resources. And that is to say, it's widely acknowledged that focusing solely on cutting costs without maintaining or enhancing the quality of care can lead to false savings and harm the delivery of effective care. It's principles of value-based healthcare, quite hard to argue with. And the focus is on sustainable quality improvement. And what it does is it brings together the cost improvement and quality improvement together, and the financial and clinical teams that are expected to deliver those two. And it brings them together under one measure of improvement. And that is one of the outputs for the transformation in terms of measurement is the value impact comparison score, or what we're calling VIC score for short. And if I speed up in my delivery, we'll get there by the end of this 20-minute section. So I'll be talking a little later on how teams can arrive at the score, but I'm just going to talk to the process itself quickly. So before we get going, we've run a pilots of this work, ran in 4 trusts. We've got 12 case studies on the website you can have a look through. They ran in acute mental health and community trusts right across all sectors. We've worked with a number of organisations, the Making Data Count team, the HPCA, so the Healthcare Project and Change Association, and those trusts that are present that are familiar with CUSA, quality service improvement redesign, all those tools, and about 100 resources are built into the back end of EVO and the handbook to be able to be used by teams throughout the process at given times. There's presentations, there's briefings, there's even value-based tools all built into the underbelly of this for anyone to implement, and it assumes a base level of competence. If you struggle with presenting data, there's a lot of tools in there for the Making Data Count team that will help you do that. If you need a project, if you don't have a PMO in your trust and you need to run that basic project, the HPCA offers free e-learning for and webinars in order to get someone up to a state where they can run a 24-week project end to end, which is what this the timeframes of an EVO, what we call an EVO journey, takes place. So as I said, we're going to do this in a sort of analogy of space exploration. We're going to have a little bit of fun with it. Why not? And we're doing this to sort of kindle enthusiasm and a positive attitude towards change and bring together different disciplines who have lots of different languages and concepts together with a shared vision. So if you don't like space, then get ready to change your mind. Right, here we go. So Your Home Planet, an NHS trust, has submitted a successful application for a rocket exploration program called EVO. And this program will ultimately help to improve the quality of life for the population on Your Home Planet. And Your Home Planet has identified 3 areas, or specialties and services, that will be the subject of the mission. And each of the 3 areas has put together a flight crew, and each crew will launch their rocket at the same time in order to orbit around their planet. Now, each crew's mission is to orbit the planet they share, each observe their specific area from space together, and use that information gathered to agree on a plan to transform and improve it for the benefit of all who live and visit there. And the EVO handbook gives the crew everything they need in order to complete this mission. So, who takes part in this? And so what we've got here is individuals from 3 core disciplines: finance, clinical, and project. And we've got different roles within that. So we've got EVO champions. So they're collectively responsible for sponsoring the entire mission. The champions aren't part of the crew, so they don't get to go to space, but instead they support the mission from the ground. And then you've got the flight crew itself. And first, you've got the leads. So they're collectively responsible for a successful mission. So you've got the finance lead there. They're responsible for the rocket's engines. These engines use data as fuel for propulsion, specifically PLIX. Work with me on the analogy, it's a little loose. And then you've got the clinical lead, and this would be the people here watching my presentation today. So you would be the rocket's captain, and you know most about the area back home. And then you've got 2 project leads, and they're responsible for the navigation and will guide the rocket's orbit. And you've got those EVO participants finally as well. And they're subject matter experts, and they're encouraged to share their knowledge with their crew to support a successful mission. So if you imagine, we've got our crews, and we've got they've applied to the rocket program, and they've successfully received their handbook. And essentially, there's 3 stages to the EVO 24-week process. So that's launch preparation, the EVO journey, and the EVO transformation. So in terms of the preparation, our crews will have received their handbook, and they're essentially preparing for launch during this period. And specifically, that would be the finance lead and the 2 project leads that will be doing this work. And the handbook will help them understand how the rocket works, what trajectory an orbit should take, and what the crew should do in the event of any unexpected variation to their flight path. The second phase is the EVO journey. That's 16 weeks. And this central component of the mission is expected to take 16 weeks, and the 3 sort of crews in the 3 separate rockets will take off at the launch together. They'll all orbit the planet simultaneously, each observing their area, and before all landing on their home planet together. And there are 3 stages to the EVO journey. You've got the launch, you've got the orbit, which consists of formulate, evaluate, allocate, and decide and plan. And then you've got the landing. And there's a few other components here. So data burns, they take place at the beginning of different stages, and they propel the rocket further into its orbit. And then these outcome markers here. So they sort of act as waypoints, and crews use these to self-assess their progress during an orbit. And broadly, a rocket that reaches marker 3 indicates that its crew is on course to achieve all of its mission objectives. So just sort of chipping into a bit of the detail, the launch marks the beginning of the mission, brings together the champions and the flight crews, and gives everyone an understanding of their mission, the timescales involved, and the different roles that contains. And then all 3 rockets will then launch, and they'll begin the orbit. So the orbit itself lasts 8 weeks, and we've got the formulate stage at the beginning. So that first stage, during that first stage, crews can expect to agree on basically 2 things. They'll essentially establish 3 hypotheses or hunches that they think are most likely to improve their area back home. And these hunches and hypotheses dictate the entire trajectory of the entire orbit from that point. They'll also agree a number of measures which will help them assess the viability of each of those hypotheses later on in the orbit. And if you remember this point now, that will be our first value tool that I'll get to in a minute. Right, so here we've got evaluate, allocate next. So by performing a data burn, the crew will use the evidence gained essentially to evaluate the probability of those 3 hypotheses. And they will also agree which of the 3 markers each of the hypotheses should be allocated to. For this stage, essentially what you've got is the objective for the crew is to establish 1 hypothesis or hunch and validate it with the data by the end of that stage. So you go from 3 to 1. And then we've got decide and plan. So if a crew has had a successful data burn, they've completed their objective, evaluate, allocate without any issues, then their rocket is likely to reach marker 3. And a crew whose rocket reaches marker 3, they'll return home, back to their home planet. They'll have agreed on a plan to measurably improve their area back home, and they'll also have agreed when these improvements will be implemented, and they will have a final date to meet and assess the impact of those changes. Marker 1 and 2, I'm not going to go into detail here, but essentially the teams can expect to reflect positively on their orbit and plan and learn future lessons in order to have a future orbit to get to marker 3, which is always the intention. After decide and plan has taken place, we've got the landing. So all our crews come back with the champions at the end and to discuss how they got on during their various orbits. However, we've got the 3rd and final phase. So that's the EVO transformation. This lasts a minimum of 4 weeks, and essentially our crews that have reached marker 3 will have a plan to transform their planet and their area back home. So this transformation will take essentially a minimum of 4 weeks, but it will depend on what the transformation looks like and the area back home. And after these changes have all been implemented, the crew will meet finally to discuss the final assessment of their mission and understand the impact that that's had. So here we've got, we're coming back to the value equation, and how are we doing for time here? Yeah, not too bad. Okay, so now, that's the end of the space roundup, and I hope that was all right and wasn't too play school for you all. So what I'm going to do now is essentially just start off with the value equation. I'm just going to very quickly go through 3 tools that teams will use during this 24-week period to get under the hood of it all a little bit. These are value-based tools, and ultimately they will lead to teams being able to assess the impact of any changes made to their specialty and service with the value impact comparison score. Okay, so you're all familiar with what we've got in front of you, and all I would ask is essentially to note the colors here, right? So quality is yellow here, and resources is red. And we're going to first move into the first tool, which is your value measures tool, and essentially that will look to clarify the value quality measures or outcome measures, however you want to call them, and will help teams establish what good looks like for their specialty. And we'll use a maternity services example to frame this. But the bottom section, the red section, resources, this is going to be used as evidence as our PLIX data. So we're using that to complete the equation. Okay, so this is the first tool I talked about. So ultimately what you've got here is you've got your quality outcome measures here, broken down to care experience, user experience, safety, quality. And this is a conversation that teams will go through in that first formulate session. You remember I flagged that at the beginning. And they will go through that process and essentially describe and give an explanation of what good looks like in their specialty in terms of outcome and quality measures. And this tool will take the team through to establish value metrics. And these are measurable, qualitative, but measurable metrics within the care outcomes, user experience, and safety quality context. And also you've got the same that will happen in the resources section here. This happens in the first session, evaluate, allocate. In that first session in formulate. Then you've got the evaluate, allocate thing. So the next tool is actually used in the third decide and plan section. So what's happened in between these is that imagine our crew that we're working, our maternity crew, have essentially got to a point where they've had 3 hypotheses, they've used the PLIX evidence to assess them, they've gone through that process, and they've actually arrived at one opportunity for clinical transformation, validated by the evidence that we've got from that PLIX data. And they're starting session 3 with an opportunity for clinical transformation, and they need to come to an understanding and assessment of how they're going to tackle that, whether that's investment, whether that's reinvestment, whether that's clinical pathway redesign, etc. And this is where the second tool comes in. So this is the value options comparison tool. There's going to be a lot of numbers on here. Bear with me, and please take into account that I haven't got much time. So I can share and have a conversation with people offline if that's helpful. Right, so what we've got here is, remember, our yellow and red. So we've got our quality and our cost. So this is our value equation. And essentially here we've got our value metrics. These were defined by our team in that first formulate session. And the team will have gone through a process outside of the session to decide on the weighting. You will notice here that we have suggested and do suggest an 80% weighting of quality and a 20% weighting of resources and cost. Teams can flex that, but that's up to your decision in your own orbit and your own team. It's very important we consider risk in this calculation and strategic factors here as well. So all of these, now we have our measures, and now what we have is our opportunity for transformation, and we've got different options for how we're going to tackle that opportunity for transformation. In this example, we've got 5 options here. And what you can see here is we've got a Likert scale. So that's 1 to 5. And broadly what that means is essentially 5 demonstrates clear and valuable, clear and measurable value generation, low risk of failure and full alignment with strategy. And 1 is obviously the inverse of that. So it demonstrates unclear or poor value impact, high risk of failure and misalignment with strategy. And our teams are going to go through the different options. And our tool is going to identify very transparently, so this is very easily shared with stakeholders for business cases, etc. That we've identified 2 as the most appropriate option to tackle that transformation. You can see a nice graph there as well. Okay, so now what's happened is we've ended decide and plan. We're going to go off and have our landing, but we have a plan now. Our crew has a plan for how they're going to transform their service. They also have a route forward with this, and I can talk about the use of the sort of PDSA model and what we call PDSA plus, because any improvement cycle or a process that you have been built in your trust, if you add the plus to it, that's including PLIX measurement in this, and that's why PLIX is going to be so useful for evidencing the effectiveness and value impact the transformation will have had. I'm not going to go into detail on that either because we haven't got time. So I'm coming to the last slide now, don't worry. If we imagine, again, our crew has got this transformation and they've actually now done the change, they've gone through a pathway redesign in this instance. So they've gone through that. They've got about a month of PLIX data, which has been very useful, but also they've changed the pathway, and so they have an understanding of what the new pathway looks like, or at least the trial looks like. Okay, so this isn't anything you haven't seen before. So this should be yellow really, but essentially this is your quality, and you'll notice we're at 80% here. So that's cost is removed just temporarily for the purposes of this tool. And essentially this quality assessment, our team has met at the end of their transformation, and they all sat down and they're going to assess the effectiveness of it. We have our quality measures. They're the same. The weighting's the same as well. And essentially the projected pathway is copy and pasted from that last tool. That's how we decided on this option. So we keep that there. But then we ask our team, our crew, well, the crew asks itself, what do we think if we want to reassess and rescore the transform pathway now we've had a month? There might be a few different things that might have come out better or worse than we thought they would do when we assessed it. Now we've asked them to essentially go through and score the original pathway. So EVO never happened. This book never arrived, and our pathway continued. Essentially, you're going to go through and assess what the essentially the specialty or service would revert to if this never took place. And we've got the quality aspirations. So based on what we have now, with a few more tweaks, a few more PDSA plus cycles, what can we think we can aspire to in terms of proving quality for the specialty or service? All those scores are then calculated and put into this. This is going to be a lot of numbers. I'm going to go quite quick because I'm aware of time. But again, slides will be available. So this is everything you've already seen before. And what we're going to do here is we're going to compare our original pathway as scored and rated by the team and compared with the transform pathway, original and transformed, and the comparison within it. That's weighted at 80%, and essentially we've got an average percentage taken of those scores. Now, in the decide and plan session, we used essentially a Likert scale, didn't we, for cost, the cost component, that bottom component of the value equation. But luckily enough, because we did our PDSA plus cycle, we essentially have the PLIX data that will essentially give us a plus minus pound percentage variance from budget, which is the original. So we can enter that into the resource score. We're also going to weight that at 20%. And then we're going to combine the quality and resource score to produce what we have is the VIC score. So this is demonstrating a 35% improvement. Now, that's quite compelling. If you've got in your trust, you've asked the medical director, the finance director, and the board to sign off, and 24 weeks later, remember we're running 3 specialties or services alongside of each other. And so 24 weeks later, you've potentially got 3 specialty services that are able to hand over VIC score with a transformation statement, which includes all the slides that you've seen and more as a result, which forms like a 3 or 4 page PDF articulating that essentially we can demonstrate a 35% improvement in value impact, and that factors in cost, quality, risk, and strategy in that calculation. And in addition to that, with a bit more time and a bit more protected time to do this work, we've got a 4% quality aspiration there. Now, I'm aware I've gone over, and so I'm not going to carry on. I've got another case study here that I can talk to you about as well, but I'm not going to. So I'm just going to stop that now and take any questions. Apologies for running over.
That's okay, Richard. Thanks ever so much for your talk. That was really, really insightful. I think everyone's got a really clear idea and picture of what the EVO program is about and how that then builds onto the costing talks that we've just listened to. So that's fantastic. And I know a number of organisations are participating in this. And I know that you're available to support organisations that wish to take up this methodology. There weren't any specific questions on the chat, and I don't know whether anybody's got any questions if they want to put their hand up or put the microphone on if you've got any specific questions for Richard. I don't believe there are. So on that note, I'm just going to give you a really big thank you and enjoy the rest of your afternoon.
Thanks very much.
That's great. Thanks again, and see you again very soon, I'm sure.
Thanks a lot. Cheers. Bye.
Cheers. Yeah. So we're just going to see if our next speaker is available. that is, I think it's Coral. Is it Coral Nicholson? Who's going to do an introduction to clinical coding. Let's see if Coral is available. Aoife, I don't know if you're still on the call in the background, whether we have our next speaker. Okay, what we'll do, we'll just give it a couple of moments, and then I'll make a decision about whether we break for our coffee break a little bit early. Okay, so just let's just wait a few more moments, and then we'll take it from there. Coral, I'm just going to check whether you're available for your talk. It looks as though you're on the actual meeting. But
Sorry, I've just joined now because I got pulled into another meeting, and then I didn't know you were waiting for me. Sorry.
That's okay.
It might be
no
running
problem.
late. Wasn't sure. Sorry.
It was actually. It was running a few minutes late. We have sort of gone over time with all the sessions. So I think you were due to finish at 20 to 3, which only gives you like 10 minutes. So I don't know whether, I think your talk was originally planned for 20 minutes, but I don't know whether you can kind of do it in sort of like 15 potentially.
Yeah, I can do whatever you want me to. Although
if that's okay.
And do you want me to do it now, or do you want me to come? Do you want me to? When would you like me to do it?
What would you like to do? What's comfortable for you?
No, it's entirely up to you. If you want me to do it now, I can do it now.
Yeah, that's great. Let's
Okay.
do that, and then what we'll do is we'll have our coffee break at just after 1:45, and then I think we'll then get back on time for our next speaker, who's Jason, at 3 o'clock.
Okie dokie. Sorry.
Is that all right?
That's fine. Isn't it typical that you get pulled into something at the last minute, and then I was all ready. Right, I'm just trying to share. Oh, it's loading at the moment. Right, let's try and share.
Would you like to introduce yourself while?
Yeah, so it's not letting me share very easily.
Mm-hmm.
You know, normally it does the PowerPoint live. Why isn't it letting me do that then? Should
I change you to presenter?
Yeah,
please. I can do that. See if I can do that from here. It's because it's not my meeting, you see. Aoife, are you able to?
Yeah, no problem. If you just give me 2 seconds.
Yeah, if we just make Coral presenter.
Yeah, no problem. If not, I can just share it from my end.
Shall we do that?
Yeah. Let me just get the presentation.
If you want, it's just I've got a lot of, you know, when you have to keep clicking, so I'm going to be going click, click, click.
No worries. Let me see if I can just try and make you presenter. Doesn't seem I have access to either. I think someone else created the meeting.
I can try and share in the normal way, like not normal way, but I can try and share this way, and then.
Yeah, if you just like maybe zoomed in a little bit, yeah.
And then hold on, I'm just gonna. Honestly. Because if I try and do this, it might. Does it look
That
like it's
seems to
full
be
screen
okay.
now?
Yeah.
Yeah, it looks full screen.
Okay, great. Okay, hello everybody. Sorry about the delay.
Deep breath.
My name's Cora Nicholson. I'm the Senior Finance Lead for Service Development at Specialised Commissioning. So we work for NHS England overall, and today I'm going to be talking through clinical coding. So giving you an introduction to clinical coding and its impact, really. So quickly, we're going to go through clinical coding, all the different types of codes, so ICD-10s, OPCS codes, HRGs, TFCs, and then go through why is accurate coding important. So first of all, what is clinical coding? So it's the translation of medical terminology as written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking medical attention into a coded format which is nationally and internationally recognised. So what is the process? Well, first of all, everything that's done to a patient when they come into hospital is put in their notes. So it's either written, paper notes, or electronically in their electronic notes. So when they go home, we have to make sure that all of that information is captured on the PAS, which is the patient administration system. And to do that, the notes are studied by the clinical coders, and then they adhere to these sort of coding standards that are recognised internationally. And then that way we have all the information in the system. So what are the two main types? So first of all, you've got ICD-10 codes. These are diagnosis codes. So what is wrong? What do they think is wrong with the patient? And then secondly, we have OPCS codes, which are the procedure codes. So once we know what the diagnosis is, what is wrong with the patient, what are we then going to do with that patient? So procedures in the forms of surgery or giving them a drug administration, for example, a drug infusion. But anyway, we take these two codes and we combine them. I'm going to show you really quickly later the code to group, which lists every single code that we're talking about here. But anyway, I'll give you an example. So here is a couple of pictures of my eldest daughter. So when she was in my tummy, one of the scans, like the 20-week scan, they picked up that she had a ventricular septal defect, which is also known as a hole in the heart. And so I can now use her as an example for my presentation. And so the diagnosis would have been a Q210, a ventricular septal defect. And at 3 months old, she then had open heart surgery. And that procedure would have been a K13.1, percutaneous transluminal repair of defect of interventricular septum using prostheses. Anyway, getting on with why it's important. So we take those ICD-10 codes and the OPCS codes, and sometimes we have HRGs, and let me just explain what an HRG is. It's a healthcare resource group. So when a patient comes in, this is like similar sort of procedures or similar things that are done to a patient, which roughly cost the same sort of amount, and therefore they can be grouped together as a healthcare resource group. Some of these HRGs are diagnosis driven, and some of them are OPCS, so procedure driven. So for example, if a patient was to come in for, say, for example, chemotherapy, and they're given a drug infusion, a drug infusion for any drug infusion is going to cost roughly the same sort of amount. So therefore it will be it won't be diagnosis driven. That's just an example. Anyway, to find out the cost of an HRG, so our Annex A, I've given you the list there. The Annex A lists all the different national amounts, so national tariffs. It's called National Payment System now. National Payment System unit prices for each HRG, and of course some are far more expensive than others. So anyway, if you continue with my example, when you look based on in this case, it groups based on the procedure, and it comes out as an EC14 A, B, and C, and then depending on the patient themselves, You know, if you've got a patient that is, you know, relatively healthy other than the hole in the heart, then they're going to group to that EC14C. But a patient with more complications will have an EC14A at the top. And as you can see on the right-hand side where it's got unit prices, we've got ordinary elective spells there and non-elective spells. In this case, she came in as we were scheduled in for an operation, therefore it's the lower cost. So and that's a picture of her today. Obviously it's not actually her, but a teenager today. So it all ended well, luckily. Anyway, what the scope of HRGs? Well, they cover pretty much everything. We've got elective inpatients. I've just listed all this. It's from the Annex A. Elective inpatients, emergency inpatients. We've got national tariffs for scans, all different types of scans, direct access, outpatient nuclear medicine services, chemotherapy delivery, and external beam radiotherapy. But what we don't have a long list of HRGs for are outpatients. They're not captured in the same amount of detail. So electives when a patient comes into hospital, non-elective when they come in as an emergency, they have the HRGs, you know, which are very, very detailed, but the outpatients are down to something called a TFC, which is treatment function code. So, for example, if I had asthma, say, and I was under the care of the respiratory service, the way you would code an outpatient is by using the TFC for respiratory service, and then it would be coded to one of those 4 HRGs, and basically they stand for a face-to-face single professional attendance with a consultant, or multi-professional, and it's first and follow-ups. They're the 4 different types. Anyway, so going on to trying to work out what the HRG is. So all the information that's captured by the clinicians and various members of staff when the patient's in, they gather all information on sort of admission method, length of stay, age, as mentioned already. So if the admission method is just an elective, then that's going to be a lower cost than a non-elective or an emergency. Of course, someone coming in as an emergency is going to be sicker and therefore needs basically more care, and that's what the national tariffs reflect. And then you've got length of stay. So as you can see in the picture, it's got the long stay trim point. So that's the sort of estimate that the patient's going to be in for. Anything over and above that will have a long stay payment. So yeah, for every day over, you get that long stay payment. But the incentive really is for hospitals to try and get patients out as quickly as possible. So that long stay payment will be sort of variable cost. It won't be full costs. Then we carry on with all the other things that we've got. So as already mentioned, the HRG is driven by the diagnosis or procedures. But if you put in comorbidities, interventions and laterality, then you end up with often with higher HRGs that are assigned. So interventions, for example, it's just a couple of examples there because I didn't really have any examples of interventions for congenital heart. But anyway, there's a couple of examples of interventions, and if you, again, laterality is where you have, so say for example you have a surgical procedure and you state that you've had it done on your left arm, for example, that's going to give potentially more income or more money will be assigned to that than someone who doesn't code that. And then I've just mentioned that you shouldn't forget the market forces factor. So depending on where the hospital is in the country, of course, our hospitals in London are going to have much higher costs than say a hospital up in Newcastle. So they just have market forces factor applied. And then going back to the value of recording these comorbidities, just to give you an example, really, I hadn't quite made it clear on this slide that the EC14, so this intermediate procedures for congenital heart disease, the drive is actually the procedure. But if you have more information based on the diagnosis, it will bump that HRG up from a EC14C up to a B or an A, which comes with it more money. So as you can see, the base HRG, in theory, a hospital would get £3,497 for the elective procedure, or 5,038 for the emergency procedure plus the MFF. But if the hospital codes more than just the primary diagnosis, so if they have, like, if they've coded the Q208 other congenital malformations or Z880 personal history of allergy to penicillin, that is obviously harder to deal with for the hospital, and therefore they will get more money for that. And the same again with the tier 2. The more information you put in, the more cost potentially can be attributed to it. I haven't gone into today about how hospitals get paid rather, because we do have a national payment system in place, don't we? And there is an elective recovery fund, but that could potentially change. So coding sometimes does go wrong, and here's an example of when it does. So sometimes, or rarely, the ICD-10s and the OPCS codes get mixed up. But I can honestly say that this one has happened because it happened to my boss probably about 15 years ago, I think, possibly a few more years ago than that. But yeah, if you look at the OPCS code, the procedure should have been coded to the K028 as an OPCS code. It was a dental procedure, and that would have grouped to the HRG CB02, non-malignant ear, nose, mouth, throat, head or neck disorder, but it was coded instead to the diagnosis code of K028, which is other specified other transplantation of heart, again grouping to an ED05 standard heart transplant. And the first one costs around, on average, about 1,699. But yeah, today a standard heart transplant costs closer to 106,000. So yeah, these things do happen, but anyway, just to be aware. And a couple of other more reasons why it's so important, clinical coding. I mean, at NHS England, we have something called parliamentary questions. We get about 3 days to gather all the information that's requested. And if we didn't have correct coding to look at, then we wouldn't be able to answer these questions. We also get FOIs, freedom of information requests, and I think we get about 5 days to turn these around. This can come from anywhere. It can come from the media. It can come from the public. I mean, often with specialised commissioning, we're often sort of part of the pathway only, so we can only give what information relates to us. But anyway, there's so many different reasons for clinical coding, and from commissioning, if we just didn't know what was happening to our population, we wouldn't be able to commission services. You have like epidemiology studies where we're studying like the trends of what's going on with health. Again, is there anything we can do about it? We've got etiology studies, which again, the causation of these health diseases and conditions. Is there anything we can do about it? And obviously cost analysis. We're always looking at our costs, trying to work out how we can reduce them if possible. And anyway, you get the general gist. And then just to go on really about how I would use coding in particular. So I cost all the clinical policies for CPAG, which is the clinical prioritisation group. Once a year, we have a budget that we try to determine which policies we're going to fund for that coming year and onwards. We get about 12 in a year. Some of them are, they're often sort of brand new drugs or brand new procedures. So I get this information in, have to speak to the commissioner and the clinician. We run various data extracts to look at what the current treatment is often. And again, if the coding wasn't correct, we're basing decisions, on this sort of information. So we hope it's as right as it can be. And of course, trying to what I'm doing from my point of view, I'm trying to come up with a finance model to cost, okay, if we were to have this new drug or new procedure in, what would be the cost to the NHS? In particular, NHS England, obviously we're interested in that, but if it was a huge cost to somewhere else in the system, we wouldn't do it. So it's really important that we try and get this information as accurate as possible. And then we get all the paperwork. There's about 20 different documents per policy that all needs to align, and then we get that to the CPAG process rather. And then we have it's a really good process. We have various patient representatives as well, and we consider everything, consider all policies in relation to their clinical benefit first and foremost, and then afterwards, once we've sort of aligned or prioritized which one would be highest clinical benefit and lowest, we rank them all like that. We then overlay the sort of costs, so that would be the average cost per patient for each policy. So the cost isn't the main driver, it's definitely the clinical benefit, but of course cost does have to have some say in it, because if it was a really, really high cost, then it would be, we probably wouldn't have the budget to fund it. And then this final slide is just about what else we do at NHS England. So a couple of links to clinical policies and service spec. So yeah, the service spec, and I do have that list there, is the paediatric congenital heart disease service spec. So that's it. I was just going to quickly show you, if I can, let me see if this will work. Is it going to work? Yeah, I can drag and drop. So this is the grouper that I was telling you about. So it's got, I mean, you probably can't see that because it's probably going to be so tiny, but it's got, this is a list of the procedure codes. So every procedure code that we do in the NHS, more or less, give or take. I mean, they're adding, I'm sure, all the time to it as new procedures come out, but that's the list of procedures. This is the list of diagnosis codes. And then the code to group is where, so in the case of the example that I've given you based on the congenital heart example, as you can see, the OPCS code, the procedure code for K131, percutaneous transluminal repair of defect, groups to the EC14. So that's how we work it out. And then just to quickly show you, I can show you, this is the Annex A. And again, it's a different tab for this. So this is the admitted patient care, the elective care, and the non-elective. And then you've got, if it's outpatients, as I've mentioned, it's based on the treatment function code. And then this is the cost, follow-up attendance, single professional. You get the general gist. Anyway, that's it in, oh, I've gone over, sorry.
That's all right, Coral. That was really, really interesting, because there is a massive importance in coding, both from a quality perspective and making sure that obviously we record the right treatments for our patients, and also from an income perspective as well. So I'm sure all our clinicians are well kind of versed in this. But there were a couple of questions that we can try and cover very, very quickly if we can. So Sarah Orr from Great Western Hospitals asked whether coding would be something that AI could be used for in the future.
Yeah, I mean, quite possibly it could be, but it's a lot. I think a lot of this information has got to be taken in context as well. But yeah, I'm sure it is. Mind you, if it's a paper, if it's a documentation and it's a doctor that's written in it, I'm not so sure whether they'll be able to read the the handwriting. But I think, yeah, it probably is. It's probably on the way, I would imagine.
It'd be good to hear whether any progress has been made in that area. I think that'd be really good to hear. And then we had Noreen was asking about the difference between inpatient and outpatient coding and outpatient procedures. I think we get separate tariffs for news, follow-ups and procedures.
That's right. So you've got your first attendances, your follow-up attendances for outpatients, and then an outpatient procedure is where they're doing something within that outpatient attendance. So whereas an outpatient would normally be, I don't know, let's say 10 minutes, is it? Maybe 5 minutes. a procedure would be longer and they're actually doing something to the patient. So therefore they get a separate tariff, and that is under the, the Annex A that I just showed you. That's under, there's a tab APC and OPROC, which is the first one I showed you. And the OPROC, which is the outpatient procedure, is very detailed. It's down to HRG level. Yeah.
And the last two questions, how can we recognise the difference in the cost of an MRI scan where one might take 10 minutes and another takes an hour?
So I'm not sure if MRI is down to different. There might be. Hold on, I was just going to quickly check. Actually, you're testing me now.
They might have different tariffs depending on what type of scan it is, I think.
Yeah, because I think
From
it's
what I
like different areas. It's like contrast. I don't know if
Yes.
this is the one with the contrast and not contrast.
Yes.
And then you've got for one body area, 2 body, 3, 4, like up to 4 or 5 body area parts. And I would imagine that's why it would take so long.
Yes, and so they would be recognised separately in terms of the complexity of it.
Yeah, yeah.
And then, quick question. I think Amanda wants to come on verbally. We'll come on to you, Amanda, in a moment. But just before we do that, just one question about how do we keep the equity between acute versus mental health in terms of coding?
That's a good question. I haven't worked in mental health for many, many, many years. I'm probably the wrong person to speak to be honest, about
Okay.
that.
Well, what we'll do is we'll try and see if we can get an answer to that. But I know it's quite a complex area, isn't it? And the tariff and the costing and the coding systems are all quite broad brush. And I know they're developing better processes for mental health in terms of costing and PBR and stuff like that. So I'm guessing it's on its way to improving the quality and the accuracy within mental health. But yeah, we will try and get an answer for you there. And I think Amanda wants to come on. Thanks for waiting, Amanda.
No problems. Thanks, Carol. It's too complicated for me to type. With regard to coding, so we moved on to an EPR system and we use Cerner, which uses SNOMED CT codes for your diagnoses lists. And it's not clear to me which ones we should use, because I'll just give an example. I'm a pediatrician and I look after children with respiratory problems. There are over 2,000 different codes for cough. It's difficult to know which ones to choose. And then that becomes a problem. It's so overwhelming that people don't know what to choose. Therefore, they put in, your information is not particularly accurate. And is there any way that anywhere where there is that there's guidance, or there are specific commonly used codes that can be used for specific areas, for example, pediatrics? It would just make it so much easier, and then we would actually use it. So I know it's not so relevant in outpatients because they're coded differently in outpatients, but those codes those diagnoses will stay on their notes and get brought in when they're an inpatient, and then when they're on an inpatient, the junior doctors don't know what to put because it's too overwhelming. So how can we get some guidance on that to make it the diagnoses list truly reflect what's going on?
I mean, it's a very good question, but it's I think we should just some hospital somewhere must have this information, mustn't they? I would imagine. So I think we need to contact them all really and find out. Someone must have it. This isn't the level that I go into for what I'm doing. So this is really like on the ground, isn't it? And but yeah, so yeah.
When you find out, can you tell me, please?
Yeah. Yes.
There is there's a one NHS Teams channel where we sometimes post questions, and you might be able to get a response through that.
Yeah,
because all the other organisations are part of that, and we kind of use that as a bit of a chat bot, really.
Yeah, absolutely.
Coral, I've put my NHS Net email address in for you on the chat.
Right. All right. Thanks very much.
I'm going to come in very
Okay.
quickly to say that what you probably need to do is use SNOMED terminology, which is the new kind of way of assessing. It puts it into clinical terms rather than coding terms. So it's not using ICD-10, but using a slightly different data set. That's how clinicians, how we think rather than how the coding system thinks. What
Yeah, but
what you try and
we
do
were
then
using
is
them. I was using
Pardon?
SNOMED. We have SNOMED CT codes, but
Yeah.
they're just too large. It's too
So
huge.
what you then need to do is what we've tried to do is we try to develop a pick list, so you get shortened lists. So if you want to something, if you have something more complex and specialized, you can then search for it using it, but you have your top 20 codes or SNOMED terminology. So ED, we've restricted all our end data entry to, I think it's about the most common 100, I think it is, terminology, kind of common terminology, and mainly the ones that are used in the emergency care data set, and you're limited to that. We've tried to do that in with the general inpatient one, but you've got to be careful, because sometimes we've got to a point where we've over limited it. So we couldn't differentiate between hemorrhagic and ischemic stroke, which is a massive difference. So you've got to then work with the different specialties to come up with a pick list that works for them, and limit it to that. So for example, pediatrics, what's common for you and what's limited to you, and then you can do that. I don't know, the different EPRs work in different ways, so I'm not sure how Cerner works, but there are ways of doing it where you can limit the pick lists.
I'm sure there are, and I'm sure other people have done it. I just don't see the point of reinventing the wheel when someone else has done it.
Yeah, but everywhere is quite slightly different. So what we found is that the pick lists that other places have had are not the same as what we see, and every specialty is different. So we have to do it ourselves a little bit. But,
and pick, as in you're saying PICK, you're just choosing.
Just a drop down. It will come up with this, and you have to do extra steps to get to the complete. So if you typed in cough, you'd come up with maybe 10 different types of cough rather than the 100 or so that are available. If you wanted to access 100, you could then do different. You'd have to go into a proper search to get anything more specific. But that's how we've done it, or we're doing it. We're still trying. The problem is that none of the EPRs have that built in. And what we have to do is we're working with an EPR, because the EPR is being developed for us as well. We can put that in as we go along, whereas the ones that are bought off the shelf takes a bit longer to do. Is that right? So it can be done. It's just it does take a bit of work.
Right, any other questions then?
I don't think there are any specific questions there, Coral.
Okay.
So just want to say a big thank you to you, and you delivered that excellently. So thank you for that. And we are running behind slightly. We're due for a coffee break now. So what I would suggest is we take 10 minutes, if that's okay, if that's enough time for you to grab a quick drink and have a break, and we'll get back here for just after 10 past, if that's okay. And then we've got Understanding Budgets and Spreadsheets with Claire Walsh, and then AK is going to wrap up with business cases, and hopefully he'll get us back on track to close at 4:30.
That variation, and that is still, so even though it's back from 2020, I think that's still something that we would look at to try and make those cost improvements. Productivity as well is something that's very much been in the press recently. As we talked about budgets before, when we look at our budgets, we will cross-reference our budgetary position as we do that financial planning round with the activity that we expect to deliver, the income that activity will bring, and what it would cost us to deliver that activity as well. cost in terms of the workforce that we would need, but also any other items that are crucial to that, maybe like drugs or excluded devices and things like that. But that cross-referencing between activity and cost and workforce is where some of that and that triangulation is where some of these conversations are heading now in terms of productivity. And recently there was some information produced to the NHS England board around NHS productivity being 11% lower post-COVID than pre-COVID. So essentially delivering 11% less in terms of numbers of patients, volumes of patients for what would be in real terms the same value as what it was pre-COVID. It's quite a blunt tool. I think a lot of us on the call will probably agree that it's just one number doesn't really tell you the story. For example, in terms of how the makeup of our workforce has changed and how our estate has changed as well. Numbers don't really tell you that. But of that 11%, it was looked into that's about 7% of it could be explained by things like length of stay being increased due to higher acuity of patients. The cost of temporary staffing. So we might have had 100 staff pre-COVID and 100 staff after, but if we've got a higher proportion of those staff which are temporary and come at a higher cost post-COVID, then that makes our services look more expensive. And then the time lag as well between some of the upfront and improvement costs to do with innovations where we've sort of invested that money or we've used a new drug which has been a higher cost, but the outcomes of those sometimes aren't seen immediately. Sometimes those are seen 1 year, 2 year, 5 years down the line as well. So those outcomes haven't yet been delivered. And finally, the spring budget did commit to for the NHS did commit to a 1.9% productivity growth for 24-25. So again, that is something that we're looking at when we set our budgets, and that triangulation between the cost of delivering our services, the workforce that we use, and the number of patients that we were able to see with that resource. So what does the future hold? We've probably picked up on a little bit of that, and you've probably covered some of this in quite a few of your sessions today already. So as I mentioned, the increasing costs of the NHS, just to give you an example around that, the pay award that often is awarded, when we do get funding from that through an uplift to our funding, it usually doesn't quite cover what the actual true costs are when we've actually, put that into the pay packets of all the employees in the organisation. So that's a pressure. Things like energy costs as well. Things like that usually causes some financial pressure. There's evolving healthcare needs, so we've got coming out of the pandemic as well and the recovery. There are funds put aside and put into organisations to assist with recovery and ensure that that funding comes through so that we can meet as much of that as we can. But it does we do find that with a limited workforce that we do need to put some extra resource in to be able to deliver that as well. Workforce shortages, so a huge reliance on a temporary staffing base, which comes at a higher cost, as well as has other implications around the experience of the workforce that are delivering our services. Inflation as well, we just mentioned that. Shortage of beds as well. So as I mentioned, increased length of stay is one of the reasons for understanding why productivity might appear to be less post-COVID than pre-COVID, due to length of stays being increased. We do have long waiting lists, so I think that's quite well publicised at the minute, as well as an ageing population and a growing population. And then we've got the growth, we've got opportunities there with the growth of digital technology as well. So with the National Institute of Clinical Excellence taking the lead on sort of understanding and appraising those kind of technologies as well. And then we've got political changes as well, which I think we kind of probably are all quite well aware of that at the minute, particularly. So how can we help to manage the pressures in the NHS? Well, there is a change in health and care landscape now with the introduction of ICBs, and a lot of the language around anything that comes out nationally and locally is around collaboration and working together, providers working with each other, providers and primary care providers working with each other at place level, and looking to work as a system, but also looking to understand the resources across each of those beyond organisational boundaries, but along patient pathways, so that we can understand the resources that go into looking after those patients and see if we can better use those resources. Standardising practice, so that's kind of links back to the Carter review around unwarranted variation as well. And then adopting best practice as well, so constantly looking at information provided by GIRFT or model hospital. I think there's the NHS impact is a new thing that's been introduced as well, to understand where there are to share best practice. I think somebody in the chat's mentioned about the EVO programme as well, and there's lots of ways that we can share innovations as well between NHS organisations. So I think that's something that we're quite good at doing. I think yes, I think there's a lot of information there to help us to adopt best practice. And then joint access across a wider patch for patients as well. So like I said, looking at fragile services and trying to understand the resources that we have available to us within a system or within a place, so that we can match those resources better for the best outcome for patients, but also in the most cost-effective way as well. I think that's the last slide. Yeah, thanks, Adam. I'm happy, you've got 3 minutes, happy to take any questions if anybody, or comments if anybody has any thoughts or reflections on that.
Thanks, Claire. Thanks, Adam. Haven't seen any specific questions in the chat other than the EVO that you just mentioned. So as we've got a couple of minutes before AK starts his talk, I'll just give the opportunity to delegates to raise their hand or just shout out if you've got any questions for Claire or Adam. I think you've done a fantastic job there. So I'd like to thank you again and wish you a nice rest of the afternoon, and we'll see you again very soon. And thanks again.
Thank you.
Thanks. Thank you.
Enjoy the rest of your day. Bye.
Thank you.
Bye.
So I think it is now time for us to hand over back to AK for our final session on business cases. Ready when you are, AK.
Thanks, Pam. Thanks for chairing the majority of the day today. Been amazing. I know there's been some technical issues and various things that have been happening. So thanks very much for standing in and stepping in and sorting it all out. So yes, I'm going to be talking about business cases. It is what we're going to talk about, and it's quite a limited time that we have. We're going to talk about the structure and what the components of a business case. Now, every individual organisation will have their own kind of specific paperwork or forms that you need to fill in, or pro formas or templates for their business cases, but they're all based on a similar concept. So we're going to talk about the concepts rather than anybody's individual business cases. We'll talk about how you can put together one, put one together, and some hints and tips. So a business case is, there's two really components, there's two kind of reasons for a business case. It's a way of asking for resource. So whether it's you want more resource to employ more people, whether it's money, whatever it is, it's a way of gaining resource. It's also, and this is the lesser known kind of reason for a business case, it's a way of showing how you've kind of reached or approached the the decision you made. So say you have a problem and why you've chosen this as a specific answer. Okay, so that's the other reason for a business case. Now, the components of a business case are all the pronouns. There's the who, what, where, when, why. And it's structured, or the traditional structure is based on this something called the 5-case model. It's what the Treasury have asked the public sector business cases to all be based on. And there are 5 components to it: the strategic case, the economic case, the commercial case, the financial case, and the management case. Now, I'm going to focus on the strategic case and the economic case. The commercial case and the financial cases often are, you need specialist input from either the contracting team, the procurement team, and the finance team, but we'll touch on a little bit about it, and then we'll also talk about a little bit about the management case. So your business case needs to be desirable. It has to be something that the organization wants. It's got to be viable in that, you know, you've got your options need to be realistic, and you've got to actually be achievable. So within a set time frame. Okay. Now, the biggest flaw in most people's business cases is that they write the business case with the solution in mind. And you can tell when you've written a solution with a specific solution in mind, because everything else is generally not very thought out. You've focused on the solution and you've not thought about all the other kind of components to it. So if you take nothing else home from my talk, the business case should be written to solve a problem. That is the kind of main driver of a business case, to solve a problem. There's a small number of people where you can improve quality to drive a business case. So you can improve quality to a small degree, but the main drivers of business cases are to solve the problem. And you've got to understand your process. So understand what the kind of financial triggers are. So within a certain amount, you can normally do it within your within the existing budgets of the CMG or your directorate or division or whatever you call your blocks. Above a certain amount needs to go to board, and above a certain amount needs to go to commissioners, and above that might even need to go to NHS England, depending on your organisation and what you're asking for. And for example, we've recently had a recruitment freeze in my hospital, so that if I wanted to employ anybody, we'd have to go and justify it. You know, even if we had a business case approved or a previous business case approved, the funding for it, we'd have to then go through another process for substantive consultant jobs. So the processes can change, and you just need to understand what your current process is. Also, to make sure you target the right group, because you might be able to get funding from different avenues or work streams. So you might be able to get funding from education or the kind of workforce deanery type thing, the education deanery stuff. If it's a workforce thing, you might be able to get it from specialised commissioners. You might be able to get it from the ICBs, depending on what it is you're looking at. So we're going to go back to the value equation. You've got to show, and I know we've repeated this multiple times throughout the day, you've got to show value. You've got to show an improvement in quality, and somehow factor in the costs. Okay. So the key components, this is the kind of overview slide. We'll come back to it in a second, but we're going to focus on the different cases first. So the first one is strategic case. So the strategic case is you've got to have a context. The strategic context to it is what you have to put together, and that's got to align to the organisation's ambitions and aims. So if you have your organisation's plan for the next year or the next few years, and what they want to achieve, what you are trying to do has to align with that. Otherwise, you're going to struggle. So what you next have to do is kind of put your case for change. So that is looking at your evidence base to show the problem. You've got to kind of sell the problem. And that might be using benchmarking data, it might be CQC reports, it might be the getting it first time reports, the model health system, NICE or Royal College recommendations, mortality reviews, root cause analysis, any of these things, you've got to build your argument, your rationale that you need to change. So to just give you some examples, so desflurane is a anesthetic gas that we use to put people to sleep. It's not a very good one in terms of the environmental impact. It's very bad for the environment. So we were pretty bad at, we had a very high usage of it compared to the national average back in 2021. And we used this data, this is from a model hospital, to justify buying bits of equipment that you could reduce your reliance on desflurane. And so you can use that data to show, look, we are a high user, we need to encourage people not to use it. We need these bits of equipment to try and do that. And we were successful in getting some money from the ICB from a green budget for doing green changes. Another one here, so we are, in terms of emergency appendectomies, we are very good. So if you look at the black line is our trust, and we are the lowest, one of the lowest proportions of patients have a less than 2-day stay for emergency appendectomies. So again, this comes from the coding. It shows you where the data is, and then you can look at your PLIX data or other bits of data to show you what your underlying cause for that is. So it's not because our surgeons are particularly bad or anything like that. The main reason for our poor performance in this metric is that patients ended up waiting for 2 days before they even got their operation because of the emergency workload that we have. So you can use that to go, right, well, we need to have some sort of increase our emergency capacity. You can't use this to just go, oh, I need to build a new theatre, but you can use it to increase your emergency capacity. And then the other aspects of the strategic case are looking at your existing arrangements. So what's your current setup? What are your business needs? So look at your activity now and look at how it might change. And then the two spending objectives and potential scope are kind of interlinked, because what you want to do is, what are you trying to do with this business, with this problem? What's the limits? Because, this business case, the problem isn't, building new theatres or is not going to be within the scope of this project. Okay, building a whole new theatre suite wouldn't be within the scope of this project. And then the spending objectives of what are you spending the money on? What are you asking money for? So for the last case, it would be for staffing, because we have theatres out of hours. We just need to increase our activity. Okay, so is it a staffing thing? Is it a capital thing? What are your spending objectives? What are you going to spend the money on? And what is the scope? So what's the potential scope of it? And we'll come to that in a bit when we come to the options appraisal. The constraints and dependencies are what's going to limit what you can do. So for a lot of my work that I do, our estates, our physical footprint is what going to constrain what I'm able to do. I'd love to have more theatres. That's not within most of my business case scope of most of my business cases that I put together. Okay, so for a lot of people, your physical space is normally the biggest thing that constrains you. A dependency is where you've got another service or another business case process that's dependent on you achieving your on this business case being approved. So, for example, if you're building a a kind of a whole new, we're building an outpatient or a day case service, okay, and one of the kind of things that are dependent on that business case, or that business case is dependent on us being able to staff it. So we need more consultants, anaesthetists and surgeons to be able to staff the day case unit. So the business case for the staffing is they're both independent on each other. So benefits and risks are positives. Risks are things that might happen. And then there's something called disbenefits, which are things that, bad things that will happen. And you've got to mitigate both the risks, things that could go wrong, and the disbenefits, so things that will go wrong. So what we used to do pre-pandemic is to have we ran a few sessions where it was a kind of dragon's den where people would come and pitch their business cases, and we'd go through them. And a radiologist came over and was talking about a new way of doing breast screening, where you inject a dye. So you put a cannula or a drip in and inject some dye, and it has very good sensitivity and specificity, so more accuracy in terms of picking up breast cancers, and that was great. But the thing we picked up on, the disbenefit, is that you would see less patients per session. So unless you mitigated that disbenefit, so the fewer patients per session, because each thing took less, so your potential screening opportunities would lead to a backlog. That's a disbenefit. So or a negative outcome. So what you need to do to mitigate that is to have more sessions. So you need to factor that in when you're doing your strategic case. So one of the ways of developing your needs, current and future, is to do some sort of demand and capacity modelling. So you can look at your activity, whatever it is, at the moment or over the last few years, see how it's changed, and then predict how much it might be changed over the next 2 or 3 years. Okay. So you kind of look at your previous years, how much has increased or decreased, or how much has changed, and then predict it for the future. And then you can see, because what you don't want to be doing is writing another business case in another year because your capacity has increased. Okay. Ideally, you want to factor that into your business case and say, look, next year you want this year, this, and the year after you want that. And they might go, you might need to put one in because funding streams are so tight, but at least then you've done half the work already. So demand and capacity modelling is really important. We're doing some work on our theatre capacity. As some of our surgical specialities have increased their workload, we haven't factored that into our theatre capacity, and it's causing all kinds of problems with staffing, overruns, all kinds of problems. So we're having to do a whole demand and capacity modelling for different specialities to kind of factor that, to determine what kind of operation times we need. So you can use the demand and capacity modelling. The next step is, once you've worked out how much you need and how much change it is, how much does that actually equate to? What's the financial impact? The grey bit at the bottom, at the side, is depending on the contract. If it's a true kind of case-based or activity-based payment system, which we've had in the past, this is the kind of income you'd get, or this is the kind of costs this would incur, and how you play it off each other, so you could have an idea of what the impact would be. So we've covered the strategic case, which is basically making your selling point. Okay, so you're sort of showing your problem and highlighting why it's important to have it solved. Okay, on the impact of it not being solved, and then you come up with your long list. And what you really need to do is, with your long list, is you've got to remember that the people reading business cases are not in your field. They're not necessarily understand all the kind of quirks, and something that you might think is obviously a no-goer or a non-starter. You may know that clearly, but somebody else might go, oh, what about this? What about this? And so if you put it into your long list and state why it's a non-starter, you know, you can put, for me, I can put, you know, building a new theatre is a non-starter because we have limited space, there's no capacity, we haven't got any the funding envelope is not big enough for that. So you could start with that. You also have your your assessment criteria and critical success factors. So if you think of your job applications and you have essential and desirable, that's basically what you're looking at. So what are your essential minimum requirements? What are your kind of, if I could have it, I would, the requirements, and that's how you put your criteria together. And then you go from your long list down to your short list. You really need at least 3 options, ideally 4, but 3 options is probably a minimum of what you can do, and it must include a kind of minimum do nothing option. What would happen if you did nothing, or what the minimum? And then you do the 2 sides. You do a quick, and this is not a detail, but you do a qualitative benefit. So with each option, what are the outcomes? What are the kind of rough? What do you see the benefits of those? Each option is, and what's the cost of each option? Okay, this isn't the kind of detailed cost analysis, but just a rough idea of how much those costs would be. One of the things that you can do is, if you're struggling to try and come up with options, is to do a kind of a formal options appraisal. And the example I tend to use for this is increasing rail capacity. Okay, so we use the increasing rail capacity between London and the rest of the country as the options as the problem that needs solving. What or scope is what it exactly what's your scope? So the minimum option would be to refurbish the existing. So the minimum option is to just improve the track between London and Birmingham. Okay, the intermediate option would be to improve the track from London to Birmingham, and then also to Manchester, Liverpool, Manchester. And the maximum would be London, Birmingham, Liverpool, Manchester, and the northeast. Okay, so that's how you kind of come up with your scope. How are you going to do it? So the minimum option is to refurbish the existing track. The maximum option is to build a whole new track. The intermediate is a mixture of the two. So, you know, it might be more clinics, it might be more visits, it might be more theatre time. You know, whatever it is, you have your different how. Who's going to deliver that service? Okay, so if it was a clinic, is it a single person clinic, and your maximum being a multi-professional clinic with multiple specialities and complete MDT? The intermediate might be a consultant and a nurse specialist. So you can look at your service delivery as a who's going to deliver it. In the context of the rail one, it would be a local contractor, a national contractor, an international contractor. Okay. The when would be how you're going to do it. Are you going to pilot it? Are you going to do it in a limited pilot? Are you going to do a gradual rollout? Or are you going to do a big bang? You know, everything at once. Okay, so minimum would be step by step. So you do London, Birmingham first, then Birmingham north west, and then Birmingham northeast. The intermediate would be doing 2 steps and then 1 step, and the maximum would be doing all the steps at the same time. Okay, funding depends on what it is you're talking about. In the context of the rail network one, it'd be either completely privately funded with money coming from the private sector and impact on passenger ticket prices. The minimum would be all public sector money. Okay, so you can have a mixture of both. So you can look at your funding, whether it's coming from internal, whether it's coming from specialised commissioning, whether it's coming from education. You can look at different pockets of money to kind of fund it, and over what kind of period of time are you looking at the funding. And if you think it's going to save money, you need to say over what kind of period of time that's going to occur. So again, this is the kind of brief overview of it all. You can say your strategic case is it needed? Why do we need to change? What are the risks and benefits? And what is the quality improvement you're going to get from it? The economic case is it value for money? Okay, what options have been considered, and then why have you chosen each option? So with that option appraisal, what you would do is you would go using your assessment criteria and your kind of essential and desirable, you kind of mark in red the options that are non-starters, mark in yellow all the ones that are possible, and mark in green your preferred option. Okay, and you put your rationale in the text below it of how you would do it. So that's your what options have been considered and which option has been chosen and why. And then the management case is a lot about to do with how is it going to be delivered. Okay, so are you going to do a pilot? Are you going to do big bang rollout? What's the impact on service delivery? So there's two sides to that. There's the what impact of service delivery. So if you're having an extra clinic, what's the impact on the other services? So if you're starting a one-stop Parkinson's clinic, a specialist clinic, so those patients are not seen in the MDT anymore or in the normal general neurology clinics, then what's the impact on those neurology clinics? You know, is it going to free up more space or reduce those waiting lists? Okay, so look at the impact on other services, positively and negatively. Okay. And then you also the other impact of service delivery is during that implementation phase, what's going to happen? So while you're rolling it out, what's your fallback option? If something was to go wrong, can you roll back to the backup option? Do you need to have an interim measure during some critical points? So, for example, when we did a reconfiguration and moved our renal transplant service from one site to another, we had to temporarily ask another hospital organisation to potentially be on standby for any renal transplants for the 24 hours where we had, things were being moved across. So you look at that kind of impact on service delivery. You might also think about what would happen if it's contingency planning. When they were building the Midland Metropolitan Hospital in the West Midlands, if you are then winding down all your other services ready to move across, what would happen if there's a massive delay? If there's a year or 18-month delay in the construction process, you can't be winding down your service to still be able to make sure you can continue your service delivery. So those kind of things you've got to have a contingency for. That's obviously a massive project we're talking about. Most projects we talk about are much smaller. And just to touch on the procurement process. So we heard about some of the procurement processes that earlier on, but there are lots of regulations and contract law, which means that you have to get the procurement team on board. When you're evaluating bits of kit or things, you have to look at the whole life cost. And what I mean by that is look at the cost over the life cycle of that product. So again, I'm sorry, a lot of it is anesthetically based examples. So if we use these kind of fiber optic scopes, so little disposable camera things that you look down people's bronchoscopes, so you look into people's lungs and look into airways and stuff. And there's two components to it. There's the disposable scope itself, and then there's the screens. And depending on how much we use it will determine which company would be the best, providing they're all equal from a kind of a technological and they meet the kind of minimum criteria that we've set. One company might go, well, each disposable bit costs £300, but we'll give you your screens for free. Another company says, well, each disposable bit costs £100, but you have to pay £100 for each screen. Okay. So if you don't use that many, if it's there for emergencies and you don't use it very often, then you might go, actually, I'll go for the one where I don't have to pay for the screens and just pay for each individual one, because that will probably work out cheaper. If you are a high user, then you go for the lower cost of the individual disposable bits, and you pay for the screens. So you have to look at how much you're going to use the equipment, over what kind of period of time the contract's for, because what you don't want to be doing is be stuck in a contract for 10 years when they've got upgrades all the time. for better equipment coming out. So you've got to look at the whole life cost of something. Then we've got things like the contract issues. So contract issues involve if you have, you might be under contract for bits of equipment, or for you might be contracted to a particular IT company. So we have a contract with, I think it's HP, and they manage all our kit over for a 5-year period, and they'll upgrade it. There's no point me trying to buy different kit that has a different computer base to it, because I'm not going to get it. The same thing with syringe drivers, syringe pumps. We have a contract with Braun or BD or whoever it is. If I want another bit of kit, I've got to make sure that there's no contract issues there. So you've got to look at your contract issues to when you're trying to look at what existing contracts are there. Do you have to, are we coming towards the end of it, and do I then need to put my requirements into the kind of wider organizational contract discussions, if we have organization-wide contracts, or is it something I can do on my own? And dofinally, a little bit about personnel requirements. So personnel requirements are, you've got to factor in that, generally speaking, when you're doing a funding arrangement for, or trying a business case for say a consultant, for example, you base it on a 42-week delivery. So they'll deliver 42 weeks out of the 52 weeks, because you factor in annual leave and study leave and all these other kind of things. But if you want it every week of the year, that's kind of 1.2 working time equivalents, whole time equivalents, is a funding you need. And the same thing for Agenda for Change staff. If you're basing on a 37.5-hour working week for your whole time equivalents, if you need to staff an extra nurse on a ward, it's like 3 or 4 whole time equivalents if you're looking at 24/7. So the HR have to have lots of templates for that kind of stuff. So they'll tell you, how many whole time equivalents you need to staff an extra person, or an extra clinic, or whatever it is. And a PA for consultants, a PA is 4 hours of work within normal hours, so that's 7 till 7. Outside of those hours, there's a slightly increased rate. So again, got to factor those in when you're looking at your business case. It's kind of, the other bits of tips are, present your ideas before you submit your business case. Get people on board. So if people are going to be part of the decision making, get their kind of support. All the people that might be affected by a business case, or by whatever your proposed solution might be, get their feedback. There's nothing worse than not being able to sort something out because of issues with we've had people expand their services without factoring theatre time, and so to get a full business case, it's important to address their concerns, incorporate their suggestions, get them to back you up, because then you're more likely to get things through if you make it part of the process. And then things like timing is quite important. So small business cases, there tend to be pots of money, unspent pots of money towards the end of the year. Now, whether that's in capital budgets for redecorations, some capital works often are underfunded. So I think last year, about January, February time, we had there was a bit of money left over. People who asked to bid for bits of capital funding for refurbishment work. If you want a big new service, you're probably better off to try and incorporate the funding from the start of the financial year, but remembering that discussions can start as early as the previous November from the April starting in April. So again, try and kind of factor that in when you're trying to time your business case. Look at, as I said earlier, look at digital transformation funds or education funds, system funding versus specialized funding. Try and kind of go for whoever you think might be the most appropriate. If you can show impact, either particularly if you're in secondary care, if you can show that there's going to be benefit to the community or mental health services or primary care, push that, because the ICB and ICSs really like that. They want more of the work to be outside the hospital, and if you can show either decreased hospital admissions or reduced impact on the community mental health side, that's always a positive as well. And finally, combining with the biggest business case is always quite useful. So if you're building a whole new building and you want some kit, if you can incorporate it, that tends to work well. You'll get some slides and they've got examples of poor business cases. So, if you're putting in diagrams, make sure that they actually make sense and are and replace text rather than having to put a load of extra text to explain the diagram. So make sure you do all that kind of stuff. And there's some links to the Treasury Green Book, which is what is the kind of gold guide or gold standard for business cases in the public sector. Just about in time. So I will hopefully have covered most of it. I know a lot of people have left, and so thank you for those of you who've stayed. If you have any questions, I'm happy to answer it any now. The slides have got some extra links to some more information. We are producing, in the process of producing, a little booklet guide to business cases, which summarizes a lot of what I've just said. And that should be out hopefully in the autumn on the One NHS website. Any questions on this talk or anything else? I'll hang around for another 5 minutes or so in case anybody wants to think of something and ask in either the chat or out loud. Thanks to all the speakers. I don't know how many of them are remaining here, but and thanks to Pam for chairing the day.